banget gitu kan.
Rapi-rapi, trompeta Indonesia.
Hello, good morning, everyone. Welcome to the Zoom meeting. Your microphone still mute, ma'am.
Sekundang setungguan, itulah perangguan. Amun kita
Hello, good morning, Director Poltekkes Kemenkes Bengkulu. The speaker from Philippines. Good morning, everyone. To all participants, I want to inform you that the seminar will ready 2 minutes again. So give yourself ready. Good morning, ladies and gentlemen. My name is Arzal Stari. It's a precious change for me to be your master of ceremony in this beautiful day on Wednesday, August 23rd, 2023. On this very special occasion, the international seminar presented by the Nurse Profession Study Program and PUI Poltekkes Kemenkes Bengkulu. Assalamualaikum warahmatullahi wabarakatuh. Respectable to the main director Poltekkes Kemenkes Bengkulu, Mem Eliana SKM MPH. The Honorable of the lectures leadership of Poltekkes Kemenkes Bengkulu, who has participated this event today. The Honorable to all our amazing speakers today, Mr. Dr. Aaron Tibay Pinluan is Assistant Professor of Nursing at Central Escolar University. Mr. John Oliveros Gregorio RN as Clinical Instructor in Manila Central University. Mem Nurse Endang Sulistiawati MKep SWKep MB as Nurse at National Cardiovascular Center Harapan Kita. Mr. Darizal SKP MPH as Deputy Director Poltekkes Kemenkes Bengkulu. Memnas Andita Ratnadiani, MKep SPKep MB as Department of Nursing, and Memners Mardiani SKep MM as a moderator, and all the participants who is joining this Zoom meeting. First of all, let's say thanks to Allah Subhanahu wa Ta'ala, who has been giving us a guidance, happiness, healthy, and mercy, so we can attend and participate this event without any obstacles. Praise and salutation upon our Prophet Muhammad Sallallahu Alaihi Wasallam, who has guided us from the darkness to the brightness. Ladies and gentlemen, welcome to the international seminar with the management of patients with acute coronary syndrome. Well, let me read out our agenda this morning. First, opening. Second, singing the national anthem of Indonesia Raya. Third, speech. Fourth, answer the pretest and showing profile video of Poltekkes Kemenkes Bengkulu. Fifth, panel discussion session. And the last is closing. First agenda is the opening. Let's open the event by saying Basmala together. Hopefully, with saying earlier, this event can run smoothly as it should. The second agenda is singing the national anthem of Indonesia Raya. The third agenda is a speech that will be delivered by the main director, Poltekkes Kemenkes Bengkulu. Dear Ma'am Eliana, time is yours.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning to all of us here. The respectable, our invited speaker, Dr. Aaron Pinuluan from Central Scholar University, Philippines. Welcome to the meeting, Dr. Aaron. Nurse Endang Sulistiowati, MCAP, spesialis KMB from Hospital Jantung Harapan kita. Mr. Darizal, SKEP MPH, and Nurse Andita Ratnadiani, MKEP, spesialis keperawatan medical bedah from Poltekkes Kemenkes Bengkulu. The Honorable Vice Director 1, 2, and 3, Head of Academic and a Head of General Administration, Head of Education Development Center, Head of Quality Assurance Center, and Head of Research and Community Service Center. And all examination and seminar participant. Alhamdulillah, Rabbil Alamin. Thanks to Allah Subhanahu wa Ta'ala, we give us mercy and blessing to meet virtually in Zoom meeting in order to attend the international seminar held by VPK Poltekkes Kemenkes Bengkulu. Salawat and salam to our Prophet Muhammad Sallallahu Alaihi Wasallam, who has brought us from the darkness to the brightness. Hopefully, we get his syafaat at Yaumil Akhir. Amin. Ya Rabbal Alamin. Distinguished speaker and participant, firstly, I would like to thank the invited speaker from the Philippines, from Hospital Jantung Harapan Kita, Jakarta, the lecturer of Health Polytechnic Bengkulu, and the seminar participant as well. The result of epidemiology study shows here one increasing prevalence of acute coronary syndrome. With WHO data also mentioned there is increases in mortality due to acute coronary syndrome, reaching 42%, and Indonesia itself, the mortality rate due to EGS reaches 32%, being one of the highest in the world. EGS is a condition where the blood flow toward the heart reduction suddenly. Just fine, like sporting a heavy object is the most common symptom. EGS includes one other as emergency cases that need time and right action. definitely proper service facilities, the number, the health personnel, expert, and access to guidelines information regarding HCEs are very needed to reduce the mortality of patients with HCEs. Ladies and gentlemen, the role of a health personnel, especially nurses, is needed in handling HCEs for that. Nurses need to know the trend and issues of cardiovascular disease globally. How to provide holistic service to HCEs patients, understanding the role of the nurse in HCEs management, including discrete planning for HCEs patients. The support increases of clinical related to test objects. Center of Science and Technology Poltekkes Kemenkes Bengkulu conduct specific activities as program management effort for patients with HCEs. By this seminar, with management of patients with acute coronary syndrome, it is expected to improve student examination and health worker knowledge regarding the management of HCEs patient. Hopefully, this event will run successfully and provide outstanding benefit for all seminar participants and the academician of Poltekkes Kemenkes Bengkulu. By saying Bismillahirrahmanirrahim, this international seminar under the theme Management of Patients with Acute Coronary Syndrome Poltekkes Kemenkes Bengkulu tahun 2023 officially open. Thank you. Bila taufiq wal hidayah. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh. Thank you for Ms. Eliana for the enlightening speech and for the officialing of the international seminar. Before we going to the next agenda, I wanted to welcoming all the participants on live YouTube. Hello, everyone. And on the Zoom meeting, so hello, good morning, everyone. Well, to all the participants, I want to inform you that we will take a screen capture as our documentation of our event today. The operator will screen the capture, so give your best smile in 3, 2, 1. Okay, we're going to the next slide. Ready? 3, 2, 1. We are going to the next slide. 3, 2, 1. We are going to the next slide. 3, 2, 1. And the last slide. 3, 2, 1. Okay, thank you to the operator. The next agenda, please enter the pretest question according to the link that will be sent on the live YouTube and room chat on Zoom meeting, while the operator showing profile video of Poltekkes Kemenkes Bengkulu.
Bengkulu is a province in the southwest of Sumatra Island. Nature, culture, and history become one, and it known as Bumi Rafflesia. Politeknik Kesehatan Kementerian Kesehatan Bengkulu was established on April 16, 2001. Poltekkes Kemenkes Bengkulu is ready to be an excellent health college that provides professional health workers and lead to global in 2025. Our alumni have worked domestic and abroad that spread in Japan for 63 people, Taiwan 20 people, Saudi Arabia 2 people, and Germany 1 person. Poltekkes Kemenkes Bengkulu is one of the excellent state health colleges in Bengkulu province. The main campus is addressed at Jalan Indragiri, number 3, Padang Harapan, Kota Bengkulu. Meanwhile, Campus B Curug is addressed at Jalan Sabta Marga, number 95, Teladan Village, Rejang Lebong, Regency. Poltekkes Kemenkes Bengkulu is equipped with the complete and modern campus facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory department of nursing, midwife, nutrition, health analyst with adequate campus equipment. Campus gazebo with 128 meter square areas used for student discussion place. Tarbiyati Siham Mosque has 457 meter square areas for 500 people with an open room design. Sport facilities. Unit of language development with internet connection and 44 computers unit for computer-based tests and online TOEFL tests. A comfortable library with selfie corner and selayang anti-korupsi corner. Unit of Information Technology that provides computer-based tests with 145 computers unit. Home theater that is used for audiovisual learning activities to all departments. Currently, Poltekkes Kemenkes Bengkulu has been accredited by BAN PT with predicate B, and it has 6 majors and 14 study programs that are already accredited by LAM PTKes.
Percayakan pendidikan putra putri Anda untuk menjadi tenaga kesehatan profesional bersama Poltekkes Kemenkes Bengkulu. Poltekkes Kemenkes Bengkulu.
Siap, kamu.
Berkualitas, Polkeslu.
Manusia.
Ladies and gentlemen, while I'm waiting you to finish the filling, I would like to share the rules of our discussion today. The rules of International Seminar Management of Patients with Acute Coronary Syndrome, Bengkulu, August 23, 2023. Participant, please set the display name to your name, underscore your department, underscore your incentive. This is for the example. Participant, please activate the video and use the background from the computer. Participants are asked to turn off the microphone during the presentation of the material unless directed by the MC or moderator. Participants can ask questions through the chat feature or directly after being invited by the moderator. Participants must fill in the attendance and evaluation link distributed by the committee on the Zoom chat, YouTube chat, and WhatsApp group. Before we are going to the next agenda, I want to read the curriculum vitae of our moderator. Nurse Mardiani, SCAP, MM. was born at Bengkulu on March 21st, 1972. Majored in nursing and worked as a lecturer at the Department of Nursing Poltekkes Kemenkes Bengkulu since 2003 till now. And she has organization experience as a secretary of Association of Indonesian Nursing Manager Nurses since 2019 till now. She is a member of Association of Indonesian Nursing Vocational Education Institution Regional 2 since 2009 till now. The training she has attended was clinical instructor training in 2015, emergency nursing basic level training in 2015, interpretation electrocardiography training in 2017, trainer of training or TOT of Indonesian Association of Emergency and Disaster Nurses 2022. She was followed the international seminar at Second International Conference on Health 2016 and the 5th Pajajaran International Nursing Conference, Faculty of Nursing, Pajajaran University 2016. And for her educational background, she was a Master of Nursing of Bengkulu University 2009. She finished her nurse program in 2003 at Faculty of Nursing, Andalas University. She is a bestseller of Nursing of Andalas University in 2002. Well, that's the curriculum vitae of our moderator. My beloved friends, brothers, and sisters, the most weighted agenda is the panel discussion, who will be guided by our awesome moderator. To Ma'am Mardiani, the time is yours.
Thank you, Aza. Thank you, Aza.
Yes, ma'am.
Okay, ladies and gentlemen, may I have your attention, please? Our seminar is about to begin. Please have a nice seat. Thank you very much for preparing yourself to join our seminar. This seminar followed by about 500 on Zoom and 1,000 on YouTube. I see, yeah. Assalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Good morning, everyone.
Morning, ma'am.
Respectable, our Director, Poltekkes Kemenkes Bengkulu, the Honorable Vice Director of Poltekkes Kemenkes Bengkulu, the Honorable Head of Nursing Department, the Honorable Leader of IKNI Bengkulu Province, the Honorable all lecturers of the Nursing Department, and the Honorable all participants of this seminar. Ladies and gentlemen, I am Mardiani, the moderator of seminar today. I'm very happy to see you here and welcome all our participants this seminar. Today, seminar is about management of patients with acute coronary syndrome. Ladies and gentlemen, today we have 5 speakers. First, Dr. Aaron T. Finluen from Philippines. Second, Mr. Joem Oliveros Gregorio from Philippines. The third, Mr. Adahrizal SKP, Master of Public from Bengkulu, Indonesia. The fourth, Nurse Endang Sulistiawati, Nurse Specialist of Medical Surgical Nursing from Jakarta, Indonesia. And the last speaker is Miss Andita, Nurse Specialist of Medical Surgical Nursing from Bengkulu, Indonesia. I apologize if I make mistake when I spell your name. I want to say hello. Good morning, Mr. Aaron. Are you here?
Yes, ma'am. Good morning.
Okay. Mr. Joem, are you here too? Mr. Joem, Joem, sorry. Mr. Darizal, Mrs. Endang, and Mrs. Andita, are you here too? Okay, yeah. Ladies and gentlemen, our first speaker today is Dr. Aaron T. Finluen. He is Assistant Professor of Nursing at Central Scholar University. He has master degree at University of the East Raymond Magsaysay Memorial Center. Now he works at Researching Postgraduate Internship. Okay, you can see that's a curriculum vitae, Mr. Aaron, on your screen. Yeah. Okay. Dr. Aaron have skill and abilities about process good interpersonal and communication skill, able to work under pressure, good time management, and critical thinking skill. He works in both English and Filipino, able to assess, evaluate, and provide urgent treatment simple cases, and computer literate. Dr. Aaron, you have 30 minutes to present your presentation. Before the presentation begin, let me inform how the presentation will be going on. First, you will be invited to present the material, and then the presentation will be continued by second speaker, Mr. Joem Gregorio. After that, there will be question and answer session. Now, allow me to welcome the speaker, Dr. Aaron, to deliver his presentation. Dr. Aaron, the screen is yours.
Good morning, everyone. Thank you for the. I hope I'm audible. Thank you for the generous introduction. Okay.
Okay.
Okay. I am. For this morning, I am asked to speak about the trends and issues in the field of cardiovascular nursing. Just a disclaimer. I am not a practitioner of cardiovascular nursing. I am a part of the faculty of the Central Escolar University School of Nursing and a medical doctor in profession. Okay. Can we go to the next slide, please?
Next.
Basically, my presentation will be based on the study done by Dr. Bozella and Dr. Heman entitled Cardiovascular Nursing Workforce Challenges, Transforming the Model of Care for the Future. Next slide, please.
Next.
Before we formally begin, let us ponder upon this statement. Nurses are the heart of healthcare. Saying that nurses is the heart of healthcare gives us the recognition and maybe a renewed dedication that our chosen profession is a foundation of an industry that is imperative to preserve human life. So much so, this highlights that healing is not merely just an issue of science, rather it gives us the essence of holistic patient care. Next slide. Nurses, regarded as the largest workforce in every healthcare institution, technically plays a vital role in maintaining the stability within the industry. And you know, since the 1900s up until this day, we have experienced periods of nurse shortages. The recent coronavirus 19 pandemic actually underscored the gravity of the acute nurse shortages. And so it has posed challenges to different organizations, health and institutions, to recalibrate their attention with regards to the significance of having a strong healthcare workforce. Next slide.
Next.
Being in the industry, especially of cardiovascular nursing, basically it requires these three skills. Very important that a cardiovascular nurse should have a more advanced cardiac scientific knowledge, which is acquired through continuous education. At the same time, nurses should have an astute assessment skills in terms of or with regard to the changing patient conditions. And very important is that based on this assessment, these nurses should have or should be able to formulate and execute quick, appropriate nursing intervention. Next slide.
Pirang na po. Kanang tayo pirang.
Now, the advances that we see now in different hospitals and in medical science, which is likely brought by modernized supportive technologies. Also, we have an advanced medications now and device therapies paired with innovative and expanded surgical and interventional techniques. This poses now a greater complexity in the field of cardiovascular nursing. So in line with this requires a broader competency requirement, which is a must for this specialized field. Next slide. In combination with that, we have higher acuity patients that is also increased, that would also increase the nursing workload demand, which is a trend that will likely continue because of the rising cardiovascular disease burden and a higher prevalence of comorbid conditions among these hospitalized patients. In the United States alone, researchers have already estimated that hospital utilization will likely increase for about 40% by the year 2025. This is in comparison with the 6% expected increase in the nursing workforce. And this clearly shows us that there is really indeed a rising need for nursing service. Next slide. According to the U.S. Bureau of Labor Statistics, you will see there are about 3 million active nurses now. And 3% of that 3 million actually has a specialization in the cardiovascular nursing. Based on the recent demographic, there is a visible shift now in terms of the race and ethnicity, as well as the educational attainment and age distribution among these nurses. And this is partly due to hiring of these younger nurses. These younger nurses that are hired increases the racial diversity. And so this trend holds a promising potential for reducing health disparities and also improving equity and access to healthcare services, because racial and language concordance between the patient and, of course, the healthcare providers would improve communication, thus improving also the trust and collaboration in terms of decision making. Next slide, please. But still, you would see that one of the problems is that overall, the nursing profession is aging. The median age of nurses now is about 52 years old. This is based on the data from the US and has remained consistent over the last decade. However, the overall distribution of the nursing workforce has shifted significantly since 2013. With more than half of all the registered nurses over the age 50. More alarming is that an even greater proportion of the total nurse workforce is nearing retirement, with about 47% of nurses over the age of 50. This problem actually extends outside the hospital. Basically, this problem also imposes an impact in terms of nursing education, because an even greater proportion of nurse faculty now are nearing retirement also, threatening to further upend an already strained nurse education system. Next slide. To add more salt to the injury, the recent pandemic, the COVID-19 pandemic, also imposes a threat to destabilize more the industry as it impacts the rate of nurse turnover. So when we say nurse turnover, this is actually defined as either an internal or external shift in a profession. So you would see that nurses have sought different opportunities, dealing now more with elder and child care and getting a remote telehealth positions instead. Next slide. High turnover rates negatively impact the quality of patient care. It also increased the financial and time resource burden of the healthcare system. At the same time, it exacerbates nurse labor shortages. Next slide. So measuring and anticipating nurse turnover is difficult because there is really no standard operational definition that currently exists. So instead, researchers evaluate the individual intention to leave as the most accurate predictor of future nurse turnover. So you would see here, this is a 2021 national survey of nurse work environment. They have found that 2/3 of the nurse respondents are planning to leave their current position within the next 3 years. And of these respondents with plans to leave, only about 38% intended to find a new position as a clinical nurse. Next slide. Practicing in a workplace that is safe, empowering, and satisfying would allow these nurses to provide the highest quality care to patients and families, while also fostering personal and professional development. Nurses who practice in healthier workplaces would report a better overall psychological health. Also, they record greater job satisfaction and demonstrate higher work engagement. It is also correlated with a lower incidence of workplace injury and a lower nurse turnover in pension. Next slide. Critical care nurses, particularly those who work in cardiac and cardiovascular intensive care units, experience high levels of burnout and an increased turnover, even before the pandemic began. But so, the recent COVID-19 pandemic intensified these workplace stressors. And the cardiovascular nurses may have shouldered an even greater burden. So as a result, the ratings of the current nurse work environment are lower than even before. And this is driven largely by burnout, lack of organizational resources, and an unrealistic workload assignment. Next slide. So high workload stress occurs when the nurses are expected to complete too many tasks in a limited period of time. And this actually results in a lower job satisfaction and a higher intent to leave. Next slide. You would see in the image a cycle. This is basically a cycle, a repetitive event, no? Poor registered nurse staffing on clinical, local, or clinical units leads to an increased individual workloads. So over time, this can reduce the overall job satisfaction and increase an individual or a nurse intention to leave their current position. So the intent to leave is strongly correlated with future nurse turnovers. And as the attrition rates climb, unit staffing worsens. And then this perpetuates the whole cycle all over again. Next slide. Nursing leadership and the healthcare organizations must focus on developing innovative plans with sustainable impact that addresses the immediate needs of nurse clinicians. So here, the HM nursing model or the Houston Methodist nursing model, this is a novel, it is an innovative approach now to nursing care that is proposed. The HM nursing model effectively prioritizes the needs of clinical nurses while also acknowledging the realities of nurse shortages. So this model actually utilizes the support of technology. At the same time, it aims to enhance nursing education and training. So the two major components of this model of care are, first, the leverage or leveraging digital technology to nursing practice, which includes virtual ICU nursing and acute care telenursing. The second one is redefining the role of nurse educators. And this is done through expanded nursing education team or unit-based nurse educators, or what do we call the PPL. Next slide, please. The first one is leveraging digital technology to nursing practice. So basically, this hybrid model would incorporate digital technology to nursing workflow. And this provides a real-time support to bedside nurses. A remote nursing operations center houses both a virtual intensive care unit and a virtual acute care telenursing program. And this provides direct support to the clinical RN on dedicated patient care units across different hospitals. They use actually high-resolution cameras and a two-way audiovisual equipment that would allow for continuous, unobtrusive patient conservation and remote consults at the bedside. So here, you would see that in the virtual ICU, experienced critical care nurses located in the remote operation center would partner with a bedside intensive care team to provide enhanced observation of critically ill patients. So this would enable earlier identification of potential decompensation. Now, when a clinical nurse requests support from the telenursing team, the patients are connected to an experienced virtual nurse. This is via a video conferencing software that is provided on the patient through a bedside smart tablet. So this one-on-one interaction now would allow a more focused and comprehensive process, whereby the nurses would have more time to answer questions, provide an in-depth teaching, and address any issues with care coordination. Next slide. So defining and growing these new nursing roles meant that the HM model could offer an innovative work alternative to experienced nurses seeking a less physically demanding nursing position. So this actually would provide also opportunities to remain competitive in the challenging nurse job world. All the while, it would also improve the retention of the highly skilled nurses, with the end point, of course, of protecting the staff levels across the system. Next slide. The second core component of this HM model is redefining the role of nurse educator. Okay, so another key component of this one involves the expansion of the nursing education. And this would allow the placement of dedicated professional practice leaders. Your professional practice leaders, or the PPL, is basically a highly expert educated nurse. And their main responsibility is to develop individualized and specialty-specific training, and also would develop plans. Along which these are also the responsibilities of the PPLs. They would extend educational support, provide a continuous mentorship, practice oversight, and to oversee the transition from a novice to an independent practice by the new nurses. Of course, they will serve as a resource person for organizational policies and standard of care, and they would do practice audits. So these professional practice leaders or your PPLs also were instrumental in the rapid development of an organization-wide nurse labor pool to respond to COVID-19 surges, further highlighting the value of a robust nurse education department and the need to increase the team to boost unit-based support. Next slide. So enhancing the PPL would reach, or enhancing the PPL reach to every unit also will improve retention among these novice and early career nurses. And this is through or by reducing the transition-related stress. Okay, this transition-related stress is rooted from a lack of mentorship, in addition to the poor preparation for complex demands or workload. And this would frequently lead to burnout and increased turnover. Next slide. So in addition of a PPL on each unit would provide a continuation of the residency supportive educational structure, and this would allow for a more individualized training strategies in the event of knowledge gaps or process changes. And this would ensure that direct care nurses would develop confidence in their professional practice. Next slide. So in conclusion, the study have raised the following highlighted points. Basically, the nurse labor shortage, although it is a problem right now, this provides us an opportunity to revolutionize traditional models of care. They also highlighted the proposed innovative HM model, which highlights the following characteristics: collaborative development process, a solid technological infrastructure, a clearly defined responsibility by the professional practice leaders or your TPLs. And of course, they also highlighted that the different health organizations must make a strategic plan, recognizing that efforts or making sure that efforts that recognize the value of experienced nurses and invest in programs that support current staff and facilitate competency for novice nurses. Next slide, please. So before I end my presentation, I will leave you with this quote. This is mentioned by Maya Angelou. As a nurse, we have the opportunity to heal the heart, mind, soul, and body of our patients, their families, and ourselves. They may not remember your name, but they will never forget the way you made them feel. Next slide. This is my source. Thank you very much.
You're welcome. Thank you very much, Dr. Aaron, for giving us such information and interesting presentation. Thank you. Ladies and gentlemen, now we continue this second speakers. Please welcome Mr. Joem Oliveros Gregorio, Registered Nurse, Master's Art of Nursing. Hello, Mr. Joem, are you here? Okay. Mr. Joem? Mr. Joem, are you here? Okay, we wait Mr.
Okay,
Joem
thank
here.
you.
Okay, okay.
Good morning.
Morning. How are you?
I'm good, and I have a hard time to unmute my laptop, as that's why I can't respond with your greetings, ma'am. So it's my
Okay.
pleasure again to be part of your seminar this morning.
Okay, thank you. Welcome, and thank you very much to join with us. Ladies and gentlemen, Mr. Joem is a master in Faculty College of Nursing Manila Central University or MCU. He is, you can see this curriculum vitae. Yeah, he is work experience, clinical instructor in Manila Central University, 2022 up to this present, as operating room nurse in Santa Lucas Medical Center, Quezon City, 2019 to 2022, as community nurse under DOH Nurse Development Program in Cagayansilo, Palawan, to 2018 to 2019, as clinical instructor in Eklan Polytechnic College, 10th year, 27 to 2017. His education, postgraduate study for Master in Nursing School at Central Philippine University at Jero, Iloilo, to 27 to 29. Okay, now allow me to welcome the speaker, Mr. Joem, to deliver his presentation. Mr. Joem, the screen is yours.
Thank you, Ma'am Marjani. That's a wonderful introduction of me. And I would like to greet also our Director of Politics, Ma'am Ileana, our Director. And of course, the faculty and staff on administrator of Health Polytechnic Kololu. And of course, I would like also acknowledge the presence of our Dean of Manila Central University, who is being with us today, Dean Melvin Miranda, the President of Philippine Nurses Association, and to all the speakers, participants, students from Indonesia and Philippines. Good morning, everyone. Selamat pagi.
Pagi, morning.
Pagi.
All right. So, as what Dr. Aaron said, that we're not expert for this for the heart, but I try my best to discuss to you the topic assigned to me, the application of holistic care and management of acute coronary syndrome. So I will give my best and to answer some of your queries later on. So to start, I would like to discuss the objectives for our presentation this morning. Next slide. The objectives of our learning objectives for our study this morning is to define the difference of ischemia, injury, and infarction, and also to differentiate between the unstable angina, the STEMI or ST segment elevation myocardial infarction, and the non-STEMI, which is the non-ST segment elevation myocardial infarction, and of course, to determine what are the functions or the management of on acute coronary syndrome disease. Next slide. Acute coronary syndrome, this is a physiologic continuum of condition caused by similar sequence of pathologic events. This is a transient or permanent obstruction of coronary artery. So this is the cause of acute coronary syndrome. Either there is an obstruction the artery of our heart. It could be transient or permanent. Next slide. I just give you the overview what is coronary artery syndrome for us to know how to manage this kind of problem. These conditions are characterized by excessive demands or inadequate supply of oxygen and nutrients to the heart muscles with disruption, thrombus formation, and vasoconstriction. That is the cause why there is inadequate supply of oxygen and nutrients on our heart muscles that could result to acute coronary syndrome. It's because of the disruption, patient and vasoconstriction on our blood vessels on the heart. Next slide. ACS, so we have acute coronary syndrome categories, which is categorized into three: unstable angina, the non-ST segment elevation MI or non-STEMI, and the ST segment elevation myocardial infarction or the STEMI. And this is the three categories of your acute coronary syndrome. Slide. So what is the difference of these three? The unstable angina is the thrombus. It could be partially or intermittently occludes the coronary artery. And if you can see in the ECG, you can see the ST segment depression on ECG tracing and the T wave inversion. But the cardiac markers, so we have the enzymes in our heart that during the damage they release. But in the unstable angina, there is no cardiac markers can be notified in our blood or can be seen in the blood tracing. Slide. So while your non-ST segment elevation myocardial infarction, or what we call the non-STEMI, they also same as partially or intermittently occludes coronary artery. But in this occasion, the same with unstable angina, there is ST segment depression and T wave inversion. But the difference of non-STEMI to unstable angina, there is elevation of cardiac biomarkers. Okay, next slide. Now the STEMI or the ST segment elevation myocardial infarction, we can categorize this. There is full occlusion of the coronary artery. Unlike your unstable and to your non-STEMI, there is partial or transient occlusion of coronary artery. Your STEMI, there is a full occlusion of the coronary artery. And what can you see in the ECG tracing is the ST segment elevation or new left bundle branch block and elevated cardiac biomarkers. So that is the difference of STEMI to non-STEMI and unstable angina. The ST segment is elevated, while your unstable and your non-STEMI is depressed. The ST segment elevation, and of course, there's left bundle branch block, which is characterized by increased QRS. QRS minutes in milliseconds or above 120 milliseconds. Okay? So you can know that in the boxes, the ECG paper can determine that the QRS is widened in the left bundle branch block because it should be the normal QRS should be 0.11 to 0.12. But what happened to left bundle branch block is the QRS is 120 seconds. A big difference, right? So that is STEMI. Next. Now, so what's the difference between ischemia, injury, and infarction? So this is how the problem now occur if these three happens: the ischemia, injury, and infarction. Okay, so next slide. So when we talk about ischemia, the myocardial ischemia is the result of imbalance between the metabolic needs of the myocardium and the flow of oxygenated blood to it. So what happened in the ischemia is if there is decrease of oxygen supply and nutrients to the heart muscles, it could lead to ischemia, in which you can see in ECG tracing the ST segment depression and T wave version. Why this happened? Because it's because of the delay in depolarization and repolarization of the heart. So when you say depolarization, that is the contraction, and repolarization is the relaxation of the heart. if there is the ischemia in the heart muscles, there is a delayed contraction of our heart. That's why a delayed contraction of the heart can be seen in ECG, the ST segment depression, T wave inversion, in repolarization. Okay, next. So the ischemia may occur either to both of these conditions, the demand ischemia, in which the oxygen demand and nutrient demands of the heart muscle is increased, but there is no enough blood supply. The supply ischemia, it could be the reduced myocardial auto supply. So may say, sir, sir, what is the difference between demand ischemia and supply ischemia? Usually the demand ischemia, if low blood, low circulating blood in which the oxygen attached to it together with hemoglobin is decreased going to our heart muscles. Okay? While the supply ischemia is some of our oxygen is not equally distributed or not distributed to the heart muscle because most of oxygen, example, exercise. So our body needs more oxygen during exercise, or some part of our body is oxygen because our metabolism is fast. So the use of oxygen also is fast. So that is why there is a decreased supply of oxygen to our heart. Like smoking, because of the low exchange of oxygen in our lungs, heavy meals, example, heavy meals. Our food needs more oxygen during the digestion. So instead of going into the heart, our body will use it for the digestion of our food. So that is why the supply of blood to our cardiac muscles is decreased. So that is the difference between demand ischemia and supply ischemia. Next slide. To injury. So if the ischemia prolongs, it could lead to myocardial injury. This injured myocardial cells are still alive, but it will infarct. The ischemia not quickly corrected. So it will lead to myocardial infarction. So as much as possible, if the ischemia is being noticed, it should be an intervention should be given to the patient to prevent the injury and further infarction of our heart muscles. So how can we see that there is injury? How will we know if our heart has an injury? The ECG tracing, you can see the ST segment elevation. Okay? Because of the injured myocardial cells. So during the contraction, our heart do not contract fully or completely, do not depolarize completely. So the ST segment is the ST segment elevates during the contraction. Since it is delayed, that's supposed to be it's normal contraction between S to T segment, but since it is a delayed, so there is a elevation of your ST segment. Next slide. So as what I have said, if the injury of the heart further occur or cannot be corrected or cannot be addressed, what happens will be there is a myocardial infarction, or what we call the cell death. So what happens if there is infarction of the heart? You can see the ST segment elevation, T wave inversion, and abnormal Q wave. That is the ECG result if you have myocardial infarction. So what is this abnormal Q wave? Abnormal Q wave indicates the presence of dead myocardial tissue and subsequently of electrical activity. So pathologic Q wave represent the transmural MI and are most commonly seen with STEMI. So your abnormal Q wave usually seen to a patient with STEMI. And you can see that in pathologic Q waves, all parts of the heart muscles, or epicardium, myocardium, and pericardium, they are all affected. So what you see is the pathologic Q wave. And sometimes this occurs within hour of onset of chest pain if there is a infarction happen to your heart. And more commonly appears 1 to 3 days after the event. And most the Q wave can be noticeable to person who suffer from MI. So even though you recover from the infarction, but there is tracing that you have a MI. Once you have an ECG, they can see that there is a Q wave being seen in your ECG tracing. So it cannot be removed. Next slide. So what is the pathologic Q wave? So if you can see the slide that I have, the PQRST, the R wave, that is the amplitude. You can see the amplitude of the R wave and the Q wave. Supposed to be the Q wave should be 1/3. Your pathologic Q wave, they are greater than the amplitude of the R wave, which is supposed to be the Q wave should be shorter compared to the amplitude of the R wave. But what happened to your pathologic Q wave is the Q wave result to be 1/3 greater than the amplitude of the R wave. And the accounts 0.04 seconds or greater than 40 milliseconds or 0.04 seconds, which is supposed to be, that is the normal wave of ECG tracing. But greater than that, it could be there's a pathologic Q wave or the STEMI happening, or there's an infarction of our heart muscles. If you can see that Q wave, abnormal Q wave. Okay, next slide. So 3 areas of damage after a myocardial infarction. It could be the ischemia, as what I have discussed, the injury, and the infarction. That is, infarction is the total damage or the irreversible damage of your heart muscles. So in ischemia and injury, it should be addressed, to be corrected, so that we can prevent the occurrence of the infarction or myocardial infarction. Next. So cardiac markers. So this is very important, the cardiac markers, because they will determine if our heart muscle has been injured or not. So what are these cardiac markers? Next slide. You have the cardiac enzymes, your right, CKMB, your CPK, your CKMB, and your troponin. So they are the cardiac enzymes, which is, if there is infarction of the heart, you can see it in your blood chemistry. If you have the CBC or blood chemistry, you can see that increased CPK, CKMB, and troponin if you have a cardiac infarction or injury. Okay, next slide. So patient who has been with chest pain or suspected for acute myocardial infarction, they are ordered to have the cardiac enzymes in 3 sets, okay? And usually the interval is 6 to 8 hours apart. Sometimes the initial result, it could be negative, but there is an ongoing infarction of the heart. So for the next hours, so it could, there are cardiac markers that could rise with after the 4 to 6 hours, or after 3 hours. The cardiac markers increase if there is a infarction of the heart. Their CKMB and troponin are released within hours of cardiac event. Next slide. So this is your CKMB or creatinine phosphokinase. Okay, they will rise within 4 to 6 hours after an MI, acute myocardial infarction. So that is why there is a consecutive test for the cardiac enzymes because, as what I have said, that sometimes the initial result, the cardiac enzymes cannot be traced. So like your CKMB or CPKMB, they will rise after the 4 to 6 hours after the MI. And the peak of this is 18 to 24 hours, which is 6 times above the normal value of your CKMB or CPK. And then it will return to normal within 3 to 4 days. Right? Then your troponin I will rise within 3 hours of acute myocardial infarction. And this is the preferred cardiac enzyme in diagnosing the acute myocardial infarction, your troponin I. So they will set this as the confirmatory test that the patient is suffering from myocardial infarction, your troponin I. Slide. So the lab will call nursing for critical lab values, and physician needs to be notified once the troponin I level is increased, because it means that there is ongoing infarction to the patient. Next slide. So patients with elevated cardiac enzymes usually undergo a stress test or cardiac catheterization for further investigation of cause of chest pain. So usually if you have the chest pain, okay, the doctor can be ordered to have an ECG, or if you don't have a chest pain, but then you have the signs or history, the doctor could request to undergo stress test, because the abnormalities or the ischemia cannot be seen on the ECG if there is no pain undergoing, while sa stress test, even though there is no pain, but if there is ischemia happens in your heart, you can see on the stress test. So that is the difference between stress test and your ECG in determining the ischemia in your heart. Next slide. So now let's go for the management of the coronary artery syndrome, your unstable angina, non-STEMI, and STEMI. So usually we focus for this management. Okay. Next slide. So the goal for treatment for acute coronary syndrome is to minimize the infarct size, then salvage the ischemic myocardium to save our heart muscles, or to prevent the extent damage of the heart muscles, alleviate vasoconstriction, reduce myocardial auto-demand, prevent and manage complication, and improve the chances of survival. So that is our goal for the patient undergoing or suffering from acute coronary syndrome. Next slide. So we have the algorithm. I just show to you how the infarction or ischemia or infarction is being managed if a person is suffering. How the hospital manage for this? How they give intervention for this? So we have the algorithm here in emergency department or in a cath lab. They did. Of course, they might give the aspirin 160 to 325 milligram, oxygen if auto saturation is less than 90%, bleed ECG, the acute cardiac cath lab, then the morphine for pain control, and nitroglycerin sublingual or spray if indicated. So what happens if there is a patient suffering from MI, has been brought to emergency room in the hospital? So there are two things happen. The algorithm, there should be an assessment which should be done less than 10 minutes, and the immediate intervention or lab treatment or treatment given to a patient. So during the assessment, what would happen? You need to check the vital signs, IV access, physical exam, the activity of cardiac cath lab, you need to activate them. Then the cardiac markers, you need to get the cardiac markers, chest X-ray, and the 12-lead ECG. So those are the assessment as being given to a patient. While what is the treatment given to a patient? is the auto administration of oxygen if the auto saturation is less than 90%. With aspirin 160 to 325 milligram if not already taken. If the patient has a maintenance of aspirin and the patient has that took the medication, the doctor may advise to take the aspirin. And the morphine for pain control and the nitroglycerin and your P2Y, your clopidogrel, that is a platelet for platelet aggregation, for antiplatelet aggregation, as being administered to patients. So those are the immediate treatment to the patient at the emergency department, the assessment. Next slide. So now, if there's already a result of the ECG, so ECG interpretation, there's ST elevation, so the patient has a STEMI. So what happens? Start adjunct therapies as indicated. Do not delay reperfusion. So time from onset of the symptoms, if this is less than 12 hours, so the patient will be first medical contact to balloon inflation. So the patient, if the patient is already diagnosed as an MI, the patient will be brought to cath lab for the balloon inflation, or what we call the PCI, or the stent insertion. And that should be done in 90 minutes. Okay. And then the if this is the high risk unstable angina, high risk back to if this is high risk unstable angina, or if this is above 12 hours from the symptoms, the time from the symptoms onset, okay? If this is above 12 hours, so the patient will be categorized into a high risk unstable angina or ST elevation. So what algorithms will be followed? This troponin elevated or high risk patient, you need to consider the invasive strategy. If refractory ischemic chest discomfort, recurrently persistent ST deviation, ventricular tachycardia, hemodynamic instability, or signs of heart failure, you may start the adjunctive treatment as indicated, the nitroglycerin, heparin, then angiotensin, the HMG, hydroxymethyl so oral beta blockers, your P2Y inhibitors, your clopidogrel, and your glycoprotein 2 inhibitors. So this would be your management if you are high unstable angina or non-ST elevation, myocardial infarction categories. If in low intermediate risk, consider the admission, chest pain, the unit, appropriate bed as follows. The serial cardiac markers, including troponins, you need to check. Repeat ECG, continuous segment. If there is ST segment monitoring, and consider the non-invasive diagnostic test. So if the patient develop one or more clinical high-risk features, the patient will be considered to the high-risk unstable angina. If none, if the patient does develop any of the high-risk symptoms, the patient will be abnormal diagnostic, non-invasive imaging, or physiologic testing. If this not happen to a patient, the patient could be discharged, and some medication will be given to the patient. Okay. So next slide, please. So that is the algorithm of the coronary artery syndrome. Now, what are the medical management that we need? Of course, as a nurse, we need to be an advocate on, or educator to our patient. What are the primary prevention to prevent this acute coronary syndrome? We need to lower the data intake of fats and cholesterol, exercising, controlling diabetes and hypertension, keeping our body weight near ideal levels, and ceasing the smoking. So those are the primary prevention in developing the acute coronary syndrome. And next slide. We also include, next slide, please, the relaxation technique, the stress reduction technique, such as your muscle relaxation and guided imagery. So these are the things that could help us to prevent the development of acute coronary syndrome. Now, so the primary prevention if there is a presence of the disease. No? So we have the pharmacologic treatment for this. Next slide. So some of it I have already mentioned, but I will discuss what are those pharmacologic agents used to treat the acute coronary syndrome. We have the beta adrenergic blockers. We have the negative inotropic and conotropic effect. It reduces myocardial contractility, heart rate resulting in decreased demand for the oxygen. When we talk about inotropic, that is heart contraction, and chronotropic is the heart rate of our heart. Next slide. So that is the function of your beta adrenergic blockers. And these are the example of your medication, your metoprolol, atenolol, or LOL. Okay. So acetobol, betaxolol, nebivolol. So those are the example of your beta adrenergic blockers. Next slide. We have also the calcium channel blockers. So it's just like the same action with the beta adrenergic blocker, but to decrease workload of the heart by coronary arterioles. Okay. Next slide. And these are the examples of your calcium channel blockers, your amlodipine, diltiazem, pilodipine, and nifedipine. Next slide. We have also the nitroglycerin. Okay, so the effect of this is relaxing the blood vessels and increasing the supply of blood and oxygen to the heart while reducing its workload. That's the effect of your nitroglycerin. Next slide. The morphine sulfate more on the treatment for the pain being experienced by the patient. So decreasing the heart rate and oxygen consumption, and reduce also the cardiac preload and afterload, and decreasing the workload of the heart. That is the, and also relaxes the bronchioles, that increasing oxygenation. That's the effect of your morphine sulfate. Slide. So we have also the antiplatelet agent. Usually they use this aspirin, your acetyl salicylic acid. Low dose long-term aspirin use irreversibly block formation of your thromboxane, platelet producing the inhibitor effect on platelet aggregation. So that's the function, the action of your aspirin to prevent or inhibit the thromboxane, which is an important component in platelet aggregation. Next slide. So we have also the clopidogrel or the Plavix, the P2Y12, as what I have said. This inhibits the ADP, adenosine triphosphate, which is needed for the platelet aggregation. It's the function of clopidogrel to inhibit the ADP, which is important for the platelet aggregation. Well, your aspirin a while ago, as what I have said, they inhibit the thromboxane. Next slide. Now we have the HMG, that is hydroxyl methylglutaryl, coenzyme A reductase inhibitor. They are the statin, simvastatin, like that. So what's the function of these drugs? So decreases the rate of the cholesterol. So the liver needs HMG A reductase to make the cholesterol. So what happened to HMG-CoA reductase inhibitor is that they inhibit the conversion of the cholesterol done by the liver, because the liver could convert your LDL, your low density lipoprotein, that is the cholesterol in your blood, convert it to cholesterol, in which it could deposit in our veins. So what happened is your HMG-CoA reductase, they inhibit the liver to convert the LDL into the cholesterol to decrease the cholesterol level in our body. Okay? That's the function of your HNG-CoA reductase inhibitor. Next slide. So this is the Joint Commission core measure for AMI. When we talk about the Joint Commission for AMI, this is the national standard measures for common diseases. So it's just like the same thing was as what I have discussed in the algorithm. Aspirin within 24 hours, PCI, the stent within 90 minutes for STEMI, left ventricle function assessment through echocardiogram, your ACE inhibitor, your angiotensin inhibitor for the effect of the angiotensin receptor blocker for the effect of ejection function of the heart, which is less than 40%. If positive for MI, aspirin and beta blockers ordered for if the patient will be discharged, and your statin or your MHG-CoA reductase prescribed at discharge. So the discharge medication to include is the aspirin, beta blockers if positive for MICP. The patient is positive for myocardial infarction. And of course, adult smoking cessation and advice and counseling. Slide. So surgical management. So since we need a holistic approach for the management, not only medical management, we have the surgical management. Okay, next slide. So in surgical management, we have the cardiac catheterization procedure. So this is what we call the balloon stenting. Okay, this is done to a patient suffering from STEMI, as what I have said, and it is done for 90 minutes from the contact to the doctor. Okay, so how it is done? Next slide. The cardiac catheterization, it is done to the insertion of the fiber optic catheter to your either in femoral or antecubital artery, and then the balloon will be inserted, and the stent where there is stenosis or there is an obstruction, the stent will be dislodged there using that balloon, and that will be permanently placed in that area where there is stenosis. That is what we call the balloon stenting. That is the PCI, for the percutaneous coronary intervention. Next slide. Okay, so that is the picture of cardiac catheterization of before that there is an stenosis. If you have seen the first picture, there is no blood supply. So after stenting, notice there is now enough blood supply on the heart after the balloon stenting. Next slide. Next is the coronary artery bypass graft. Usually this is done if the stenting, there is failure of stenting, and there is a greater damage of blood vessels. So 2 or more coronary artery damage, the coronary artery bypass graft is being done to save the heart muscles or the heart functions. Okay, the coronary artery bypass graft. Okay, next slide. So the coronary artery bypass graft surgery involves the bypass of a blockage in one or more of the coronary arteries using your saphenous veins, your mammary artery, or the radial artery. Okay, so they use that saphenous vein and your mammary artery or radial artery. Okay, in cabbage, what they call that cabbage, the coronary artery bypass graft. Okay, next slide. Almost there, we are on the end part. So now in the cardiac rehabilitation, since we are doing the holistic care, so after the discharge of a patient in the hospital, or after the procedure or any procedure done to the patient will let the patient to live as full, vital, and productive as life as possible. But you may ask, how long will the patient can go back to his normal activity after the cabbage example of the surgery of the heart. Usually patients given the 12 weeks to be normally functioned the patient if they undergo the coronary bypass graft. So let the patient, after 4 weeks, the patient now can do some activities, but not those strenuous activities. They remain within the limits of the heart's ability to respond activity and stress. Exercise. So how it will be done to a patient with undergo cabbage after the procedure? Be done twice a day for 20 minutes. But during the exercise, if the patient experience cyanosis, cold sweat, faintness, extreme fatigue, severe dyspnea, pallor, chest pain, pulse rate more than 100 beats per minute, dysrhythmias, and BP greater than 160/95 millimeter per mercury, the exercise should be stopped. The patient might suffer again the myocardial infarction, and then take the prescribed medication at regular basis. Resumption to sexual activity after 4 to 6 weeks from discharge and lifestyle changes. So, of course, if this sexual activity, you need also to get the advice of your doctors. What would be the necessary things you need to consider before doing this? And of course, as much as possible, we need to change the lifestyle. As what I have mentioned, the preventive measures, it should be followed. We need to educate as a nurse, we need to educate the patient, we need to educate the relatives or the immediate family of the patient in order to prevent the reoccurrence of the disease. Okay? And of course, we need the moral support to the patient, or some patients may experience depression because of the problem. We can refer them to the support group where the patient, as a goal, the patient could live fully his life. That help him to recover from his illness and help him to have the positive outlook in his life after the disease. So that would be the goal, our goal as a healthcare provider, to recover the patient from the disease, to have positive outlook, and to live the life fully to the best that they can. Okay, next slide. I think it's the reference already, and thank you. That's all about my topic for this morning, and God bless us all.
Okay, thank you very much, Mr. Joem. You give us a really good and interesting presentation, yeah. Nowadays, I think currently these are many cases related to ACS. This probably mostly due to lifestyle, stress, and lack of exercise. Yeah. Okay, ladies and gentlemen, it's time. This time we come to question and answer session. Yeah. I will limit 5 questions from all participants. Please, you can push or click your raise hand button or drop the question in chat box. Please mention to speaker that you want to ask. Okay, I give you 1 minute to give the question in the chat box.
Menjadi perawat adalah suatu pilihan hidup, bukan tentang seberapa sering kamu mengabdi, melainkan seberapa besar pengabdianmu bagi mereka. Menjadi perawat berkualitas, menciptakan tenaga yang profesional.
Dalam hal ini, agar kita tidak mengalami kegagalan dalam mencari identitas, hendaknya kita memanfaatkan waktu sebaik mungkin dengan mencari dan mempelajari integritas sebaik-baiknya.
Okay. Okay, until now I have a question from Zahira, yeah. From Zahira, she asked to Miss Dr. Aaron, yeah. This question is how to keep nurses do not experience excessive fatigue that can cause them stress. To Dr. Aaron, yeah, how to keep nurses do not experience exercise excessive fatigue that can cause them stress.
Let me clarify. The question is how do we keep the nurses not to experience so much stress, isn't it, in the work? Okay. Basically, stress in the work, I think, is very common for us nurses. It's really part of our work. But the thing is, I think it is very important now with the advance of technology that we can utilize these advances in technology to help us in rendering patient care. Not necessarily to totally eradicate the stress in work, but to at least help us manage the stress so that we can be more productive during our work.
Okay, we know nurse have many tasks, yeah, when he our job, yeah. This question, the next question from Chandra Buana, yeah, Mr. Chandra Buana, please.
Yeah, thank you, Mr. Moderator. Next question from Mr. Aaron, Mr. Finluan.
Dr.
Yes,
Aaron,
sir.
Dr. Aaron, yeah.
Yeah, Dr. Aaron. How are you, Mr. Aaron?
I'm okay, sir.
I'm too interested about your story about the virtual ICU nursing in your program in Filipina. But maybe you can share with us what kind of model of virtual nursing that you're building in Filipina hospital. Thank you, Mr. Aaron.
Actually, sir, currently I'm not an ICU nurse. I focus on teaching. At the same time, I'm a medical doctor. So I'm not really that familiar with the situations here in terms of the CCU. But in comparison with the things that I presented a while ago, because most of the modalities now, the innovations in the modalities of care in the ICU that I presented were based on a trial in the US. So, but here in the Philippines, as of the moment, we are still more on the traditional approach to care. So, unfortunately, virtual ICUs is not yet implemented here. We're still probably majority of the private institutions, big private institutions here in the Philippines are maybe formulating strategies to apply that. But as of the moment of all the hospitals that I was able to go into during my internship and recently, well, we still do the traditional approach of nursing care.
Okay, I think it's the big homework for us how to get the virtual in nursing ICU for the cardiac arrest and etc. Especially for the ICU unit. Maybe like that. Thank you, Mr. Aaron.
Thank you, sir.
Thank you, Mr. Chandra. The next question from Miss Sachi, yeah? Sachi Balkis. Okay, Sachi Balkis, please, your question.
All right. Thank you so much for having me, and thank you for the opportunity. I'm so sorry. Can I ask that my voice can be here?
Yeah, your voice is clear.
Yeah.
Okay.
All right. Okay. As we know that many nurses in the world have the biggest problem. The problem is sometimes they got a double shift or they have too many workload, and it may cause a stress to the nurse. And my question is, what should we do to reduce the stress of nurse? How can we make them still work perfectly without feeling any stress because of the workload? My question is coming to Mr. Aaron. Thank you so much.
Okay, that's actually a good question because that's also a problem here in the Philippines now. I think one very important thing is that we consider the nurse to patient ratio. Majority of the stress, I think the work-related stress that's experienced by nurses is there's too many patients being taken care of by as few nurses. That's why the effect is actually, since we have nurse shortages, the effect is that some nurses have to do double shifting. So I think if we balance nurse to patient ratio, that would help solve the problem. But unfortunately, it's quite difficult to attract a lot of people to go into nursing. So as different literature would suggest, we must do a strategic plan uh, focusing on the use or utilization of any advanced technological support that we can use, as just like what I presented a while ago, they did virtual ICU nursing. So that's a good alternative actually if some hospitals would invest on that, because uh, you just need a few nursing clinical bedside nurses, and with the aid of virtual ICU nurses that are expert on a certain field, they could give an assistance to this on-duty clinical bedside nurses. And this assistance would actually help these bedside nurses in terms of the monitoring. That's actually a big help.
Okay, it's been almost the development country mostly use traditional tool with nurse, yeah. Okay. Okay, the next question, please. Okay, this question from Ria, yeah. Ria asked to Mr. Jem, yeah. How and how to approach management of acute coronary syndrome patient with type 2 diabetes mellitus and chronic kidney disease? Mr. Jom, please, your voice, we didn't hear. Unmute, okay.
All right. So thank you for that question. So you talk about the type 2 diabetes mellitus and chronic kidney disease. They could be the precipitating factors that could affect the acute coronary syndrome. Okay. So in type 2 diabetes, usually our blood is the increased blood sugar, which contributes to the blood become thicker. So usually we need to manage that the blood circulation, because that if our blood is high in sugar, they could lead to development of thrombosis. So with type 2 diabetes, we need to correct the problem, because sometimes the coronary syndrome could be, some causes for that is the underlying diseases or the diseases that could contribute to the circulatory function of our blood. So that is why we need to correct first the patient's problem, which is a type 2 diabetes. The good circulation could help prevent the occurrence of this acute coronary syndrome. While in kidney disease, we can relate that to acute coronary syndrome by the decreased supply of, or the decreased demand of oxygen to our heart. Why? Because if we have kidney problems, we have the low blood counts. It is very important for the to carry oxygen to the heart. So once we have the kidney problem, we have the low blood or CBC, lead to the ischemic demand of the heart, which can contribute to our acute coronary disease. So we need to correct our kidneys so that it will improve the production of our CBC. Okay? And of course, some of our kidneys also, some of the hormones that could lead to produce stress hormones contribute also to the occurrence of our coronary syndrome. That is why in order to prevent the occurrence of acute coronary syndrome, we need to correct this type 2 diabetes and chronic kidney disease because they could affect the development of this disease. Okay? So the circulation and the supply of oxygen or the demand of oxygen in the heart muscles, if we have this kind of disease, is being affected. So that is why they are part of the risk factors of developing the acute coronary syndrome.
Okay, thank you. It means keep stable sugar on blood for the diabetes mellitus patient, yeah, and correct kidney for the patient with kidney disorder, maybe, yeah. Okay, the next question from Mahmuda Rahma, yeah. Mahmuda Rahma say, thank you for the great material from Dr. Aaron. Yeah, she say it's a really effective way to develop an individual and customized training develop. Yeah, the question is how to manage time and cope with recurring pressure. How to manage time and cope with recurring pressures.
Sorry, let me clarify. How to manage time and
how manage time? How manage time? Manage time.
So technically, how to manage time?
Yeah, manage time and cope with recurring pressures.
With recurring. Sorry, I think you're muted. With recurring, sorry. You're muted, ma'am. You're muted. It's muted.
Recurring pressure. How to manage time and cope with recurring pressures.
Okay. To cope with the recurring pressure.
Yeah.
I think that time management goes with experience. At first, I understand at first it would really be difficult, especially if you're assigned in a critical care unit. If it is really your first time, it would be really difficult how to manage time because some patients would really be toxic in terms of the health, delivering nursing care. But I think in terms of the time management and coping up with the pressure, it goes with experience. And I so believe with continuous mentorship, as what proposed by the study, the appointment of different PTLs, their professional practice leaders, their continuous mentorship would help a novice nurse or those new, in particular in the field of critical care, to develop a technique in terms of their time management and how do they provide nursing care to these types of patients.
Okay, thank you, Dr. Aaron. Next question from Nandita. Ya? Nandita, okay. Nandita, please. Okay, Nandita. Okay, we wait Nandita question. The next question from Suratman Muhadi. Yeah, Suratman Muhadi. What is the most practical way of diagnosing coronary disorders or early symptoms in everyday life? And maybe the question to Mr. Jem, yeah?
Thank you for that question. In order for us to monitor, because sometimes we have different, what I have discussed a while ago is the unstable angina. We have different angina, stable angina, transmittal types, or that is the variant angina. So in order for us to really, there's silent angina. So sometimes that there are angina, we could not recognize the signs and symptoms, but they automatically, they suddenly come with us. Example, your transmittal angina could lead to sudden death. We are sleeping, and then once we arise, it could occur. It could lead to sudden death. That is the transmittal angina. If we talk the stable angina, we can determine the onset, the time, and the cause. So that's why we can monitor. This is stable angina. It could last only 3 to 5 minutes or 10 to 15 minutes, the stable angina. So the best way for us to, the silent angina, there is no symptoms, but still you have the angina. You can only see that the best way is for your ECG, and of course the monitoring of your early signs and symptoms. That is the chest pain. Usually we need to, if we have the heart problem, we must be particular the chest pain that we have. What we have chest pain, is this a stable angina, or this is the unstable angina, like that, so that we can seek early intervention. Because as the heart disease, sometimes we say call this as a silent killer. Sometimes there is no symptoms being felt or manifesting to us. So the best way is for us to have our regular check-up or ECG, because those biomarkers only happens if there is the infarction, like that. But the best way to monitor is the signs and symptoms, and of course some ECG monitoring or the stress test, the workups, in order for us to know if we have the ischemia in our heart, because there are ischemia that do not manifest symptoms. As what I have said, they can only seen to the stress test, but you don't have pain any felt. But it can be seen in your stress test that you have an ischemia. Okay, so that's why we need to have the check-up or workups in order for us to know what is the condition of our heart. Okay, so I think that's the most effective way, is to have our medical workups or some test or exam for us to monitor our health, especially in our heart.
Okay, thank you, Mr. Jom. Mostly the causes sudden death, yeah, from the angina, yeah, unstable angina especially. Okay, the next question from Agus Salim from Polkesmas. Mana pertanyaan? Okay. Please, Agus Salim, you can ask question. Agus Salim, Polkesmas, yeah, from Polkesmas. Mr. Agus Salim, are you here?
Okay, thank you so much.
Okay, thank you. Please,
sorry, I am, hi, good morning, magandang umaga po from the Philippines. I'm really so sorry, I'm not using the camera because the connection here is not really quite good. Thank you so much for the moderator, for the time that you are giving to myself to ask questions.
Okay.
I have a question to Mr. Pin Luen, because I saw that he is a registered nurse, and another side he is a medical doctor. Mr. Pin Luen, good morning po.
Good morning, sir.
Yeah. I really would like to know any updated informations in the Philippines related to the cardiologist disorders at this moment after the COVID pandemic 19. Would you like to share to us about the new management in the new management of cardiologist disorders in the Philippines after pandemic of the COVID-19 at this moment? That's only of my question. Thank you so much. I do hope that I can get a new information from the Philippines about the cardiologist disorders there. Thank you so much.
Okay. Actually, my field of practice, sir, is not really into cardiology, but I have consulted some of my friends who are in training, still in training for cardiology. In terms of as of the moment now, because here in the Philippines, actually, we're in the new normal, so majority of the protocols have returned to how it was pre-pandemic. The approach actually still, like for example, here in ACS, in the treatment of acute coronary syndrome, it's really more of it are they follow the same protocol, sir, as of the moment. They still follow the AHA protocol and the local guidelines that are present here in the local guidelines that have been used here in the Philippines since 2014. The guidelines are still the same, and it was discussed by Sir Joem a while ago. We still follow that as of the moment, sir.
So, what is the new program of the Miss? Sorry, Miss Moderator. I have another questions to Sir Gregorio. Hello,
Okay,
sir.
okay.
Magandang umaga po.
Magandang umaga, sir.
Okay, Sir Gregorio. My question is, actually, what is the new rules of Philippines government, especially for the Secretary of Health in the Philippines, related to the cardiologist disorders at this moment? Because we know that in Indonesia there is a new transformations from the governments to have many special disease in Indonesia. In Indonesia after the pandemic of COVID-19 a while ago. Would you like to share to us about the new regulations of the Secretary of Health in the Philippines to us in this conference at this moment? Thank you so much.
Thank you for that question, but as much as possible, I want to answer your question about the new protocol implemented by the DOH to the Philippines about handling the acute coronary syndrome. But as of now, I want to say sorry because I don't have really know is the new program of the DOH about the in managing the acute disease. But as of now, every hospital they have the algorithm as what I have discussed a while ago. That is the new algorithm in managing the acute coronary disease. And that's still our algorithm. And as what I have experienced, I work in St. Luke's Medical Center. You have the same thing algorithms that the assessment and the intervention is still the same. So the cath lab in emergency room, you need to have that 90 minutes intervention to the patient who will be suspected for STEMI disease or infarction, and it should be done to cath lab, this referral to the cath lab, and then the continuous assessment. I think that is still the same, that the algorithm in managing the acute coronary disease. But as of now, for the DOH a way of managing the algorithms, I don't have the idea if they have different algorithms being implemented for the general. I think because sometimes every institution, they have a specific algorithm how to manage that acute coronary disease. Depends upon sometimes the the availability of the equipments of the hospital or the standard of the hospital because of sometimes the availabilities of the supplies. But okay, the standard supplies for as a standard algorithm is what I have discussed. The assessment and the what are the management during the assessment if they have see this kind of signs and symptoms and what would be the intervention. It either be in the needs of invasive procedure if the patient is already developing the STIMI like that, the PCA or stent insertion. I think that is still the implementation, but they are still doing at the St. Luke's, but I have in the hospital where I came from, that they do the same procedure. The cath lab is doing that kind of procedure after the assessment done and evaluating the needs of the patient. Still the same. They're using those medical management, nitroglycerin, aspirin. They are still using that one.
Okay, thank you so much. Maraming salamat, Gregory. Okay, see you. Bye-bye.
See you. Bye-bye. Thank you, Mr. Agus Salim. Maybe this is this last question from Mr. Agus Salim, yeah? Our time is up to Dr. Aaron and from Dr. Aaron and Mr. Joem, yeah? Thank you very much to our speaker today, Dr. Aaron and Mr. Joem. Wait a minute, yeah. I want.
Thank you so much.
Yeah. Okay.
Thank you for the invite.
Okay. Now it's time to give the online certificate to our speakers. Yeah. Please welcome to our director to give the certificate to Dr. Aaron and Mr. Joem. Okay. Okay. First certificate to Dr. Aaron. Okay, we wait our director. Please, Ma'am.
Okay, thank you, Ma'am Dian Mardiani.
Okay, thank
I'm
you.
sorry I didn't open the camera. Thank you
Okay, it's okay.
very much to Dr. Aaron Pinluan and Mr. John Gergio. Hopefully the knowledge is heard is useful for all of us. Here we submit a certificate as a resource person. Have this is useful.
Okay, this is certificate for Mr. Aaron and Mr. Jom, yeah. Thank you, Mr. Aaron and Mr. Joem, yeah. For a minute, I beg your time, second, yeah, to take a photo with all participants today. Okay, committee, please take a photo, please. Photo. Okay, it's finished. Thank you very much. See you next seminar, okay?
Thank you, ma'am, for the invitation.
Yeah. Bye-bye. Thank you.
Thank you.
Thank you,
Bye,
Mr. Jem.
Have a blessed day ahead of us all.
Yeah, thank you so much, and thank you very much. Mostly, Dr. Aaron and Mr. Jum, you can stay here, or you want to leave this Zoom? It please for you.
Thank you, ma'am.
Dibungkus daun salad, rapi-rapi, berbekal Indonesia. Ikan pais, lemah rasanya, makan dengan nasi putih, panen-panen, pulang dari rasanya lebaran, makan sebungkus salos-salos, nasi sepiring sudah habis, rasanya tanggung, rasanya lebaran, panen terindah, rintik-rintik.
Okay, ladies and gentlemen, may I pay your attention? We continue to the next. Ladies and gentlemen, may I pay your attention? We continue to the next presentation. The presenter is Mr. Darizal. Mr. Darizal was born at Kerinci on September. He is postgraduate in Educational Science, University of Islamic Fatmawati, Bengkulu. He worked at Poltekkes Kemenkes Bengkulu as a deputy director too. You can see the curriculum vitae about Mr. Darizal on the screen. Mr. Darizal, you here?
Yes,
Yeah.
ma'am.
Yeah. How do you do today?
Fine. I'm very fine. Thank you
Yeah.
very much. Yeah.
Yeah. Thank you, Mr. Darizal. Mr. Darizal, you have 20 minutes to present your presentation. Before the presentation begins, let me inform how the presentation will be going on. Mr. Darizal will be invited to present the material, yeah, and then the presentation will be continued by the fourth speaker, Mrs. Endang. After that, continue by the last speaker is Mrs. Andita, and then we will move to the question and answer session. Now, allow me to welcome the speaker, Mr. Darizal, to deliver his presentation. Mr. Darizal, the screen is yours.
Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Thank you, Ma'am Mardiani, its moderator.
Welcome.
Good morning, all. The honorable speaker, moderator, the honorable our participant and committee. I'm very happy to be this seminar forum. Thank you for inviting me as a speaker. I will share information about modification risk factor for acute coronary syndrome and focus on specific LDL cholesterol modification. Okay, I want to start. Kelihatan, Matt? Halo? Mardiani?
Iya Pak, sudah kelihatan Pak.
Oke, thank you.
Sudah kelihatan, Pak.
I want to share a modification of risk factor for acute coronary syndrome. Coronary arteries are blood vessels that supply oxygen, blood. Thank you. The myocardium. Acute coronary syndrome, coronary heart disease, occur due to the narrowing of the coronary arteries. This condition is caused by atherosclerosis. In this video, atherosclerosis. Excuse me, Mardiani, and then I to speak and bilingual ya, English and Indonesia. Jadi pada atherosclerosis ini adalah proses pembentukan plak ya, itu yang terjadi. Atherosclerosis is coronary plaque that form on the inner walls on the coronary arteries, which can block blood flow. Jadi di sini akan terjadi pembentukan plak yang tentunya mempengaruhi pada dinding bagian dalam arteri koroner yang dapat menyumbat aliran darah. Ya. Jadi plak ini terbentuk dari tumpukan kolesterol. Nah, jadi nanti saya akan fokus pada modifikasi kolesterol. This plaque is formed from cholesterol deposit is a long process that takes years. Jadi maybe kita perlu hati-hati ya para audiens sekalian kaitan dengan kolesterol, karena dalam video yang saya tayangkan tadi ketika sudah terjadi atherosclerosis itu yang memiliki gejala itu hanya dari riset yaitu hanya 18%. Selebihnya belum menunjukkan gejala. Jadi ini karena proses yang long time ya, bertahun-tahun. Nah, and then LDL cholesterol, the primary target of therapy. Jadi ini dari new research, ya riset terbaru. Kita mencoba fokus memodifikasi itu adalah di kolesterol yang spesifik di low density lipoprotein. Jadi beberapa riset yang menyikapi bahwa untuk penyakit jantung koroner itu kita fokuskan kepada modification low density lipoprotein. Selain itu uji klinis banyak menunjukkan bahwa dengan terapi penurunan LDL mengurangi risiko penyakit jantung ya. In addition, recent clinical trial purposely saw the LDL lowering therapy reduce risk factor and coronary heart disease. For this reason, adult treatment panel ini yang populer ya saat ini, adult treatment panel HCPC. Kita bagaimana mengidentifikasi level LDL kita nanti sehingga ini bisa mengurangi risiko kita terkena sindrom koroner. Sehingga tujuan utama terapi kita nanti ini adalah titik potongnya adalah untuk memulai menurunkan atau mengontrol yang namanya low density lipoprotein. Jadi kolesterol yang fokus di low density-nya. Nah, tentunya kita harus mulai dari risk assessment ya. Risk assessment first step dan risk manajemennya ya. A basic principle of prevention is that an intensity of risk reduction therapy should be adjusted to a person absolute risk. Ya. Jadi prinsip dasar pencegahannya adalah intensitas terapi pengurangan risiko harus disesuaikan risiko absolut seseorang. Jadi nanti kita akan lihat bagaimana komposisi kolesterolnya dan juga bagaimana faktor risiko lainnya. Hence, oleh karena itu, langkah pertama dalam pemilihan terapi penurunan LDL adalah menilai status risiko seseorang. Ya, lowering therapy is to assess a person risk status. Risk assessment includes measurement of LDL cholesterol as part of lipoprotein analysis. Jadi, penilaian risiko memerlukan pengukuran kolesterol LDL sebagai bagian dari analisis lipoprotein dan identifikasi penentu risiko yang menyertainya. Ya, jadi di sini ada kata-kata identification of a confirmed risk determinant. Ini kita lihat group table 2. Ini adalah AP3 classification of LDL cholesterol. Di sini dia under 100 is optimal, 100 until 100 to 9 ya, near optimal, above optimal. Ini adalah batas ya Bapak Ibu, para peserta sekalian yang ditoleransi di sini. Kemudian di 130 ini sudah borderline ya. Ini jadi di sini yang harus dicermati adalah ketika LDL kita itu pada posisi lebih dari borderline ya. Jadi 130, 160 apalagi sudah very. Nah, biasanya yang sering muncul adalah total kolesterol ya. Kolesterol ini posisi toleransi desirable-nya adalah under 200 ya, ini. Mungkin kan terjadi sifatnya kolesterolnya tinggi, kemudian HDL-nya juga rendah. Itu bisa saja ya, bisa terjadi. Jadi di sini HDL kolesterol yang baiknya is very good under 40 ya. Okay. Next. Major risk factor exclusive LDL cholesterol, just modifikasi LDL goals. Jadi ini tujuan nanti kita utama adalah bagaimana melihat LDL, kemudian disertai dengan penyerta berikutnya. Di sini ada cigarette smoking, hipertensi, kemudian low HDL cholesterol, ada family history of rheumatoid chronic heart disease, ya, kemudian umur. Three category of risk that modify LDL cholesterol. Di sini adalah chronic heart disease and chronic heart disease development. Ini LDL kita harus LDL-nya harus di bawah 100. Ketika dia multiple ya, multiple ini harus kurang dari 130 ya. Kemudian 0 to 1 risk factor kita usahakan itu di bawah 160 ya. Nah, therapeutic lifestyle ini yang fokusnya sekarang beberapa riset ya, change in the lowering therapy. Adult treatment panel activity recommends lifestyle to chronic heart disease. Therapeutic lifestyle change yang di sini ada reduce intake saturated fat. Ini harus dikurangi, harus di bawah 7% total ya. Ya, biasanya kita hitung dalam bentuk kalori. And cholesterol under 200 mg per day, therapeutic option, and LDL lowering, size plan, sterols, kemudian increase viscous soluble fiber. Ini biasanya kita harus konsumsi serat ya, kemudian penurunan berat badan dan peningkatan aktivitas fisik ya. Jadi dalam hal Peningkatan aktivitas fisik ini kita kembali kepada konsep yang sudah diajarkan, itu adalah per weeks itu harus minimal 150 menit, or per hari itu adalah 30 menit, ya itu yang bagus. And then berikutnya ini kita akan melihat ya modifikasi yang apa yang harus dilakukan dalam model step therapeutic lifestyle change to LDL, ya itu di visit 1, itu bagaimana kita berupaya memulai model langkah-langkah dalam perubahan therapeutic ini. Di sini di kunjungan pertama yang dilakukan adalah increase reduction to saturated fat and cholesterol. Jadi memulai terapi gaya hidup dengan pengurangan lemak dan kolesterol dan mendorong aktivitas fisik dengan boleh mempertimbangkannya sampai adanya rujukan ahli gizi. Ya di sini. Ini harus dilakukan selama 6 minggu ya, 6 weeks. Kemudian baru kita mengecek kembali ya pada evaluasi LDL respon. Nah, kemudian apa yang harus dilakukan di sini ya? Evaluasi, reinforce reduce saturated fat and cholesterol. Consider adding plants, sterol, increase fiber intake, consider referral to dietitian. Jadi ini di visit to kunjungan. 6 minggu kemudian ya 6 weeks kita harus evaluasi dan ini harus dilakukan dan kita tidak boleh putus asa ya, kita harus selalu tetap semangat mengevaluasi bagaimana modifikasi LDL ya. Kemudian di kunjungan 3 evaluasi LDL respon, if LDL goal not achieved, consider a drug ya. Jadi sini kita sudah harus melakukan initial to for metabolic syndrome, intensity weight management, and physical activity, consider referrals to dietitian. And then ini kita lakukan participate 6 bulan. Adherence to lowering therapy, adherence to both patient are finding is key to approximating the magnitude of the benefits demonstrated in clinical trial to cholesterol lowering. Ini reference ya, cholesterol and program, kemudian dokter spesialis vaskular, and thank you for your attention ya. Maybe ini yang bisa saya sharekan kaitan dengan modifikasi materi di risk factor for acute coronary syndrome. Thank you very much, Ma'am Mardiani.
Thank you, Mr. Darizal.
I'm sorry.
Yeah, thank you for giving us such informative and interesting presentation. I think important our life we have to maintain our weight here, our weight, and always check and make stable our tension, yeah, our hemodynamic vital maybe, yeah. Okay, thank you very much, ladies and gentlemen. Now we continue the 4th speaker. Yeah, please welcome Mrs. Endang Sulistiowati. Mrs. Endang, are you here?
Yes, thank you.
Yeah.
Assalamualaikum warahmatullahi wabarakatuh.
Yeah, welcome to our seminar today. How do you do today?
Alhamdulillah, I'm fine. I'm good, thank you.
Alhamdulillah. Okay, audience, I want to introduce our speaker, the 4th speaker today. Yeah, full name is Mrs. Endang Sulistiowati. She is nurse at Cardiovascular Center Harapan Kita. She is nurse specialist of medical surgical nursing, ya. Okay. Now she work at Akbar Pelni, Jakarta. Ya, Jakarta to 2018 to 2020, ya. Mrs. Endang was born at Bandung on July. The major specialist in nursing, ya, maybe, ya. Today she won presenting about role of nurse and management of ACS, acute chronic syndrome. Yeah. Mrs. Endang, you have 20 minutes to present your presentation. Yeah. And then we next continue the Mrs. Andita as a last speaker today. Mrs. Endang, screen is yours.
Thank you.
You're welcome.
Okay. I would like to share my screen first. Okay. Allow me to share. Wait for a minute. Okay. Thank you very much for Poltekkes Bengkulu, Mrs. Aliana, Miss Andita, and all the staff of Poltekkes Bengkulu for inviting me to share about acute coronary syndrome. Yes, maybe if I can speak English, maybe some in Indonesia, right? Okay. First is we can see the heart. This is the heart. We have the heart with 4 chambers, and then in the heart there's perfused with coronary artery, right? Actually, Mr. Joe M already present about this. In this presentation, I would like to present about definition of HES and symptom and treatment. Of course, the last is conclusion. Acute coronary syndrome, is emergency condition where is a lot of people sudden death with HES in home or in hospital, in hospital, outpatient and inpatient. And worldwide, ischemic heart disease is the single most common cause of death, and frequency is increasing. An account of for almost 1.8 million annual death, and 20% of all deaths is in Europe. How is Indonesia? Actually, I have data from Jakarta. Actually, all data was not quite different from now. There is almost for 30% of patients diagnosed with HS admitted to ER in Jakarta. So one third the patient going to emergency room is because of the acute coronary syndrome. Then estimated acute myocardial infarct in Jakarta is 24,453 cases per year. So why we must concern about HES? Because in brain we have mnemonic, but time is brain, but in heart we have name time is muscle. Why? Every 15 minutes the heart not perfused, there is ischemic cell in myocard. I will make point. Okay. And then if 40 minutes the heart not perfuse, the cell will there's necrotic in the cell, and 3 hours the necrotic will more and more, and 6 hours the necrotic would make the heart not good in contraction. So if the heart necrotic, the performance could not back good again if there is less perfusion or necrotic condition. So what is acute coronary syndrome? Actually, Mr. Joem already performed. There's acute coronary syndrome is umbrella term used to cover a group of clinical symptoms and compatible with acute myocardial ischemia, which is imbalance between myocardial oxygen supply and demand, which occur due to sudden blockage of coronary artery. There is acute thrombosis induced by rupture or eroded atherosclerotic coronary plaque with or without concomitant vasoconstriction, causing a sudden and critically reduction in blood flow. This we can saw the picture here. There's healthy artery. There's no plaque. There's good flow in the vascular, and there's the plaque build up. We know the plaque or atherosclerosis is build up of cholesterol and other substance, such before Mr. Before me said that the build of the atherosclerosis is cholesterol, and then this is the one is which is the artery or vascularly blocked because of the plaque, and then sometimes there is rupture of the plaque and make it block the vascular. So what happened during HCS? There is plaque rupture and precipitate thrombus formation. You know that the atherosclerosis is build up of cholesterol, penumpukan cholesterol, and then make it narrow the line of the vascular. So the blood was not good enough, not enough to perfuse the cell. This is the spectrum of pathology and clinical ischemic heart disease. This where the patient feel there's a stable angina, which is the plaque is in the vascular but not the vascular, and then this is partially occluding thrombus, whereas the plaque eroded and then make a thrombus, but the thrombus just reduce the flow, and then this is actually, if we saw the ECG, we can see end-stemming ECG. There is a ST depression or normal ECG, and this one, if the thrombus occluded fully vascular, there's no flow to the cell, because we know there's blockage. We can see the ECG is ST elevation in the ECG. So as a nurse, we must know how normal ECG. Minimally, we must know normal ECG to find there is something abnormal in the ECG, and then we must fast to consult to the doctor if there is a abnormality of the ECGs. And this pathophysiology, there is early atherosclerosis. There is bullet from cholesterol, infiltration of LDL cholesterol, macrophage, lipid to form foam cells, and endothelial function is impaired. In this season, the patient not feel pain, asymptomatic, and respiratory usually present. And this one, vulnerable plaque, there is lipid-rich necrotic core here, built up in the vascular, and then, but no restriction to flow. But actually, if because of there is pro-inflammatory mediator, so we can see even there's no symptomatic or asymptomatic, there is increasing of the marker like CRP markers, and then plaque. If there's a rupture of the plaque, there is expose of tissue factor and lipid core to blood. There is thrombus. Maybe lumen may occlude or not. If occluded, there is total occluded like ST elevation. It's really emergency, and then it's called acute coronary syndrome. And if just reduce, but also not just reduce, even just reduce, it really make low for the perfusion of the cardiac. So it will be pain for the patient. It's the acute coronary syndrome with elevation of troponin. Now we check the HS atau high sensitivity of troponin because of the sensitivity. The HS troponin is more high even than the troponin E and troponin P. And this one is stable plaque. If there is no erotic or there is rupture, no rupture, so there's dense fibrous tissue and smooth muscle cell, and then the lumen will reduce. So and narrowing, yeah. So the flow will reduce. So this is stable coronary artery disease. This for the patient sometimes will feel pain for if they in exercise. And with this one, with acute coronary syndrome, even the patient in the rest, they feel pain. This is the risk factor of the HS. We can see that there's traditional risk factor and non-traditional risk factor, such as age, family history, hypertension, cigarette smoking, diabetes, hypercholesterolemia, low HDL cholesterol, and hypertriglyceridemia and obesity. And this is one is non-traditional factor. So what is the sign and symptom? Sign and symptom for HS is chest pain. What kind of chest pain? The pain in the chest is like chest discomfort. Someone with acute coronary syndrome cannot point it where is the origin of the pain. It's centrally. So if someone can point it, maybe is, oh, there is a pain in my heart. See, pointed in one location, or there is not typically of chest pain of angina. This is one we can see there is a probability of angina, ischemia pain. There is central, feel like pressure, squeezing, gripping, heaviness, and tightness, exertion atau stress related, and restore sternal. And then sometimes it's left-sided and dual and etching. But if there's stabbing, right side, tearing, ripping, burning, sharp, fleeting, shifting, pleuritic, and positioning is lower probability of the ischemic. We can see the red one is high probability, and so the green is low probability, because some chest pain is can describe maybe pneumotorax, or there is dissection aorta dissection, or abdominal pain, or else. So, and then prolonged time for the chest pain is more than 20 minutes at rest, and radiation to arm, neck, and jaw, shortness of breathing, diaphoresis, nausea, and on female elderly and patient with diabetic may have less typical symptoms. Sometimes for female just feel diaphoresis, short of breathing, diaphoresis, nausea. So more women and female can less come to the ER because not typically of pain they feel. Okay. This is the chest pain evaluation. Actually, there is one mnemonic tool to evaluation to assess the pain. This name is PQRST. But now I would like to assess with Socrates. What is Socrates? We can see this S for side, where the location is the central or retrosternal. The O is onset. This is the onset is sudden or acute onset. The characteristic is the C is for characteristic, whereas the characteristic is heavy or burning sensation. The R is the radiation. The patient with the acute coronary syndrome will feel the pain radiate to the arm or the jaw, or sometimes with or and the jaw. An A is for association, which is with pain with associated with dyspnea, nausea, or sweating. And the time is duration more than 15 to 20 minutes. Yeah. And E is for exacerbation. Patient with HS sometimes relief of symptom by nitrate, but if the patient with total occluded, even we give nitrate, the pain will not release. The severity worsening by symptom by activity. And what is primary goals in HS? The first, if the patient goes to ER, so the patient must put it in the right in the red room. Yeah, there is and then identify STEMI and transfer to the perfusion. And then relief or ischemic chest discomfort and reduce amount of myocardial infarct, then treat acute life-threatening, because HS will lead to death if we not treat them well. Yeah. And what must we do if the patient comes to the ER? The first we say that triage promptly to the right category and place on the trolley. Ensure for CAB or cardiac, airway, and breathing. Do immediate ECG. In the AHA, we must take the ECG less than 10 minutes. We must have the ECG. So we know there is a STEMI or non-STEMI or else. Yeah. And we must do insert the EFI line, cardiac monitor, and then if the saturation less than 19%, we must give oxygen. And then we give aspirin, and if we know there is chest pain, we can give aspirin, or we know there's STEMI, and check history and examination. And then for diagnostic, now ECG should get within 10 minutes of arrival. This is the guideline from the guideline of AHA. Yeah? And cath lab must be activated as soon as the STEMI is confirmed in PCI center. So in our ER, we have one room for primary PCI. Cardiac enzyme especially check high sensitivity troponin and check KMB ratio. And then lab like complete blood count, chemistry, liver function test, and lipase. This is help to differentiate between chest pain and intra-abdominal pathology with chest pain. And then X-ray, we must check, is useful in diagnosis and another myocardial, other than myocardial presenting in chest pain. Like if the patient there is a pneumothorax or there is dissection aorta, we can see in the X-ray to eliminate there is angina or there is NSTEMI or STEMI. This is the initial assessment for a patient with suspected acute coronary syndrome. We know for the clinical setting symptom and vital sign, there is angina pain. If the patient can locate the pain, there is no or low typically of pain, and then we ask the patient how the pain is. Before I explain about the pain, if there's typically pain of myocardial infarct, so we must check the ECG. If normal or there is ST depression mild or ST depression more than 2 point in extremity and 1 point in precordial, it can be called ST depression. And if there is ST elevation, it's really must aware about this. The patient is occluded, yeah, and then we must check the lab is troponin. If there is no increase in troponin, the patient is ruled out of myocardial infarct. But if the troponin is increased and high, there is rule we can rule it. Yeah.
Your time just 2 minutes.
Oh yeah. Okay. Okay. So this is the Joam already presenting, and then this one the elevation evolution of ECG for ST elevation. Okay, this is the initial treatment. Before we make mnemonic MONA. MONA is morphine sulfate, oxygen, NTG, and aspirin. But now we can present it. Does morphine just can we give for a patient with pain? Because actually, for some reference, the morphine is associated with morbidity and mortality in a patient with HS. So it just but in some registry there is no association. So we still can give morphine for the patient. But the oxygen, all time we give the oxygen is always give the patient oxygen even the saturation is more than 75. Yeah, but now we just can give oxygen for saturation less than 19, because actually oxygen is harmful for the patient if there is still normal saturation oxygen. And then nitroglycerin, we can give nitroglycerin to relieve the pain, but if patient hypotension or still intake sildenafil, we cannot give NTG. Yeah, but now still we just give we give aspirin and ticagrelor. So the mnemonic now maybe can change with astimona. Yeah, from the mona to the astimona. The first can give us aspirin and then ticagrelor, and if we need it, we can give morphine, oxygen, and NTG. Then, if the patient is STEMI, can consultation to cardiology, give medical therapy with DAP or dual antiplatelet therapy, aspirin and ticagrelor, and give anticoagulant. And then the patient must first have reperfused ischemic tissue. Yeah, this is the algorithm, whereas the patient here in home feel pain, and then he call the EMS, and then come the ambulance. Actually, in Jakarta, 10 minutes is not reasonable because traffic. Yeah, and then if the patient showing to the hospital, if the hospital is PCI center, so less than 19 minutes, the patient must have reperfusion. And if the patient is known to PCI center, so from the home we must find the PCI center, and then so the time is 120 minutes. And then if PCI center, there is primary PCI, so we reperfuse, open the vascular with catheterization. Yeah, this is the catheterization we have. Who should get PCI? All the STEMI and non-STEMI should get PCI. Actually, STEMI with ischemia symptom less than 12 hours or 12 and 24 hours if ongoing ischemia, and STEMI with electrical or hemodynamic instability, and STEMI with refractory ischemia is needed to get the PCI, to catheterization. Yeah, and then with the AFA 2017, a primary PCI strategy is recommended over fibrinolysis within indicated time frame. So even the patient have fibrinolytic and it failed, it must really fast to get to PCI center to make it reperfusion. Yeah, yes, the picture of how there's a plaque, and then there is occlusion for thrombus. There is deflated balloon from the catheterization, the site, and then the stent inflated, so the blood can flow here. For thrombolytic, for ACS, is always review contraindication before giving thrombolytic. There's this is contraindication. Yeah. Post thrombolytic care, if still not released, so mass transfer to PCI capability facility, may still need rescue PCI if there is no ECG evidence of reperfusion. This is the sequence of an evolving myocardial infarct. This is the evolution of coronary STEMI, acute coronary occlusion with STEMI, and then this is the for the reperfusion. If the patient still less than 12 hours, and then there's reperfusion, this is the one what can ECG the patient have if the patient reperfusion. If the patient more than 12 hours, it could be still called PCI. So what nursing problem priorities? As a nurse, we must can managing the pain and ischemia. So like before, we can give morphine or make the comfortable place for the patient, monitoring for a potential complication, promoting adequate tissue perfusion, and reducing anxiety. The conclusion, ACS should be diagnosed as soon as possible. Reperfusion is the goal for treating ACS. The nurse play a critical role in assessing, monitoring, and caring. Thank you for the time, and I'm sorry, maybe delay for the time, so I cannot present all of my presentation. Thank you.
Okay, thank you, Ma'am Endang. Your presentation is very thankful, informative, and very interesting. Now we continue the last speaker today. The last speaker today is Mrs. Andita. Yeah, please welcome Mrs. Andita. Mrs. Andita, she is a lecturer at nursing department. Okay. Ma'am Endang, you can change your. Okay, thank you.
Okay.
Okay, thank you.
Right.
Okay, ladies and gentlemen, now we continue the last speaker today. Please welcome Mrs. Andita. The full name is Mrs. Andita Ratnadiani. She is a lecturer at nursing department, Poltekkes Kemenkes Bengkulu, postgraduate from Indonesia University as nurse specialist of medical surgical nursing. Yeah, you can see this curriculum vitae, Ma'am Andita. Okay. Okay, Ma'am Andita, I give you 20 minutes to present your presentation, and the screen is yours.
Thank you, Ma'am Dian. Hello, all participants. Here I want to share. Okay. So my presentation is already begun. Yeah. In this session, I like to talk about discharge planning for patients with acute coronary syndrome. In previous session, we already talked about the management and the trend and issues in ACS. And now for the closing, I think it's better for us to talk about how the patient after acute coronary syndrome should be discharged. Next. Okay. So why discharge planning is needed and why is discharge planning is an important factors? There are several reasons, and the first is the mortality rate of cardiovascular disease worldwide is increased. As we know that in 2019, an estimated of 17.9 million people died from cardiovascular disease. And this is surprisingly is about 32% of all global death. Yeah, so this is a major mortality cause. Yeah. And the death from cardiovascular disease surge, so it increased 60% globally since the 3 decades. Yeah, so for the last 30 years, the death from CVD is always increased. The trend is increased. The second is the high risk of recurrent cardiovascular events. So the patient with cardiovascular events tend to have the higher risk to get the recurrent events. The third is the need of prepare the patient to leave hospital. Maybe previously, when we talk about discharge planning, we can say that discharge planning is start when the patient is discharging. But the fact is that discharge planning could start from the first patient register to the hospital. And then the last is why discharge planning is needed, because it is useful to avoid the need for patient rehospitalization, because there are data that show the hospitalization, rehospitalization after ACS is still high. The next slide, please. Okay, so this is the general consideration about the discharge planning. The fact is the patient with prior cardiovascular events, for example, a heart attack or stroke, are 5 times greater to have another event. So it is sure that patients with coronary artery disease are at very high risk of recurrent acute coronary syndrome. This is give us the reason, that we need risk factor management and adoption of healthy behaviors. As we know that coronary artery disease is the major cause of acute coronary syndrome, and the management is including the healthy behaviors management. So there are some bad habit or bad lifestyle that should be changed in process. So we need the discharge management. This is the key. And what is the purpose? The discharge management useful to decrease the risk of unfavorable clinical outcomes such as death or recurrent heart attack. Next slide. So actually, what is discharge planning? So we can say that discharge planning is a multidisciplinary hospital-wide process, and this is the underlying word, a multidisciplinary hospital-wide process. So it include the involvement of many professionals in healthcare service, such as physician or the medical doctors, the nurse, and maybe medical rehabilitation, pharmacists, and other healthcare professionals, all involved in making a discharge planning. And it should be able to help patients and their families developing a feasible post-hospital plan of care. What will the patient do at home after they discharge? This is the key of discharge planning. So discharge planning is very important and critical to ensure the continuity of high quality care. As we know that the care of the patient is not just at the hospital where the patient register or admission, but it will follow and still continue until the until the patient get discharged. The next slide. And in previous slide, we talk about ensure the high quality of continuity of care. Now, how to ensure the high quality of patient care? The first is medical, I mean the professional healthcare should assign the responsibility for what? For undertaken the discharge management of the patient right after the patient register. And the second is the healthcare provider, I mean the professional, including nurse, should identify the expected post-hospital care needs. So to identify the expected post-hospital needs, the nurse as one of the team should assess what the need of the patient, because the need of the patient is very multifactorial and very multidimensional. And the third is develop with patient and families appropriate discharge care plans. So after the healthcare providers identify the expected post-hospital care needs, they should be able to develop an appropriate discharge care plans, and it involving the patient and the families. So in the process, when the teamwork develop the discharge plan that's suitable for the patient and families should get involved. This is the key. And the fourth is assess patient and families. Assess patient and families for what? Of course, to follow up what to do next after the patient's discharge. How to assist if the patient are discharged? Of course, we need a referral profession, and we need the multi-sectoral cooperation, to ensure that the patient still in the continuity of care. The last is consider patient's medical, social, and financial needs. This is the factors that should be considered whenever we talk about discharge planning. To what place the patient will discharge, to home or to primary healthcare facilities, or the family member's house. And then what is the social environment of the patient that can be support or maybe give challenge to patient to implement the healthy behaviors whenever patients are at home. And the third is financial needs. Of course, the financial needs is also the main factors that contribute to the health system. So we have to consider these financial needs, whether the patient use an insurance or the patient is fully pay for their own health services. Next slide. Next slide. Okay. So this is the essential elements of discharge planning. The first is early identification of patient. What should be identified? First is we have to know in what does the people or does the patient need the complex follow-up or complex discharge planning management? How the support system behind the patient? And the second is patients and family education. We know that if we want to involve the patient and the family into a discharge planning management, we have to make sure that we give best education to patient. And before we give the education related to what patient needs according to the disease, in this case is acute coronary syndrome, we have to know or we have to assess first, how far the comprehension of patient and family about the disease. The third is patient and family assessment and counseling. This I already mentioned before, it is include the assessment of whole thing, that support the patient to get discharged. And we have also need the counseling to make sure that not only the physical aspect of patient are fulfilled, but also the psychological aspect and the social also. The fourth is plan development. After we assess and give counseling to patient, we can develop a strategy or a plan how the patient will discharge, what the source that needs to be involved in the development. And when we arrange a development, the plan for discharge planning, once again, we should give it to the patient and families. So the patient and the family member can choose what the best plan that they can commit in the next or the future program. The next is plan coordination and implementation. We know that nurse is not working alone. There are several sources. That should be give contribution. For example, the physician itself, the medical doctor that responsibilities in the care of the patient along the hospitalization, and then the pharmacist, because there are several drugs that should be given in the medication, and also the nutritionist maybe, yeah, all the thing it should be work together, yeah, in implementing the discharge planning. The last is post-discharge follow-up. So it's not end by the discharge of the patient, but we have also follow up after the patient discharge. Do they still commit the program that we already discussed before? The next slide. Of course, while undertaken a discharge planning, there are several challenges. Yeah, there are many challenges that come from so many resources. The first challenge is the discontinuity between in and outpatient providers. There is a gap, or there is a fragmentation between in-hospital care and outpatient providers. For example, in hospital, after the patient discharge, the patient will be taken care by the maybe primary healthcare facilities such as puskesmas maybe in Indonesia, yeah, community health services. In this case, there should be the best communication, yeah, between the hospital and the another healthcare providers, so it will ensure the continuity of care. The second is discrepancies in medication list before and after hospital stay. We know that medication for ACS can be very fluctuative, and the dosage maybe need to be tailored, and it depend on patient condition. So there are maybe the differences between medication lists in hospital and the medication that patient take at home. So this is the second challenges, yeah. The third challenge is inadequate preparation for discharge. This is what we talk about actually, yeah. Inadequate preparation for discharge because of the teamwork, or maybe the plan is not suitable for the patient. And the next is disconnect between provider information and patient understanding. Sometimes we have to make sure that the information given to the patient is understandable and can be understand by the patient. The last is a burden of care after discharge. After the patient return home, the responsibility of taking care of the patient is not by the healthcare provider as in hospital anymore, but to the caregiver, whenever whether it is given to the family members, spouse, children, or another family member. So burden of care is a very critical thing that should be considered whenever we talk about the discharge planning process. Next slide. Of course, one purpose of discharge planning is how to prevent adverse event after the discharge. So we need the comprehensive discharge planning and contributing of patient and family involvement to get positive patient outcomes. Next slide. To make sure that there are no adverse events after discharge, we have to do some discharge planning strategies. And there are several discharge planning strategies that are developed by several units, yeah. For example, the care transition programs, re-engineered discharge, and the third is we have ideal discharge planning. Ideal discharge planning is one of the discharge planning strategies that broadly used in medical settings. Next. So previously, we are sure that the discharge planning need to involve the patient and family. So we have to engage patient and family in the discharge process when actually there are at least 4 time point of discharge planning. Yeah, at admission, during the hospital stay, prior to discharge, and on day of discharge. Okay, next slide. This is the comparison between standard discharge planning and also and modified discharge planning management. Yeah, at admission, for example, the healthcare provider just transcribe admission to hospital record and reconcile medication list. But in modified activities, the healthcare provider should identify caregiver, elicit patient and family goals, inform the patient and family about steps toward discharge, and give a time to ask questions. Next slide. And this is the the second time point, yeah, during the hospital stay. This is the comparison between standard discharge planning and modified discharge planning. When we involve the patient, we are not only transcribe and reconcile, but also give the education to the patient. Next slide. Prior to discharge, if in standard discharge planning, the healthcare provider only give coordination to home-based care and special equipment needs, but in modified discharge planning process, there are also activities that should be involved. For example, the preparation for transition to home, schedule to discharge planning meeting with patient and family. So there is a meeting with patient and family before the patient discharge, yeah, and the medical team or the healthcare provider, such as nurse, have to offer to make follow-up appointment. Next slide. Okay, and this is on the day of the discharge, yeah. Again, the standard discharge planning, just reconcile and give written discharge to patient and family. But in activities that according to the modified discharge planning process, we should reassess the patient and family comprehension about the disease and review the reconcile medication, write down follow-up appointment, and write down hospital contact person. So whenever the patient or family needs any question, they can contact the contact person. Next slide. So what is nurse role? There are at least 5 roles in discharge planning process. The first is as a referrals. As we know that nurse will refer the patient to the another healthcare facilities right after the discharge. And of course, the nurse should understand the procedures. Although the nurse are not involved or not directly give the therapy to the patient, but to give the education, a nurse should understand the procedures in order to give explaining to the patient and families. And the relation is also to teaching, yeah. There are some procedure, maybe how to take care patient at home that should be teach by the nurse to the patient and families. The fourth is post-treatment preparation. So the nurse should prepare what are the needs of patient and families after the discharge. And the last is also the nurse is a part of the teamwork that involved in a discharge planning process. Next slide. So this is the care process after acute coronary syndrome. Panatoni et al. Give a proposed third care process in acute coronary syndrome. The first is when the patient in a hospital discharge. The second is discharge pathway models. And the third is the treatment targets and healthy behavior implementation. Next. Now we talk it step by step. The first is hospital discharge. This is the fundamental cornerstone actually. And at this stage, we have to make the risk stratification. So it will determine what plan should be given to patient and families, and what the proper discharge planning that should be given to the family and the patient. Next. The second step is discharge pathway models. So the Italian consensus document propose the models that we can use in clinical settings to give the risk stratification of the patient. After we scoring how the risk of the patient to recurrent event of cardiovascular event or the need for the healthy lifestyle, we can divide it into three risk stratification. Whenever a patient shows signs and symptoms of clinical heart failure or the left ventricular dysfunction during hospitalization, so the patient should be put into the high clinical risk. So what is the strategies? The patient need inpatient cardiac rehabilitation. If the patient have a multivessel disease, incomplete or no revascularization, or unknown coronary anatomy, have diabetic mellitus, chronic renal failure, or peripheral arteriopathy, and the history of angina, so patient is should be put to the second high thrombotic risk. So what is the strategy? The patient should get ambulatory cardiac rehabilitation. So the difference from the first is inpatient. It means the cardiac rehabilitation should start in the hospital, but the second one, the yellow one, the cardiac rehabilitation can be performed in the outpatient facilities. And the third is if the patient give no high clinical risk and no high thrombotic risk, so the patient should be put into the low risk. That means the need of the outpatient clinic, just outpatient clinic, and non need of cardiac rehabilitation. Next slide, please. Okay, so this is the third step. What is the step? This is the implementation of healthy behaviors and the treatment targets. We know that there are at least 5 factors that we should be considered whenever give the treatment. The first is physical activities. There is a proof that the physical activities can reduce the risk of the recurrent cardiovascular event. And of course, the second one is smoking cessation. Smoking cessation is a challenge for the ACS patient actually. The third is healthy diet. How kind of diet that should be given to patient after ACS? The medical show that the need of the healthy diet include high fiber and low glucose, low natrium, and then the risk factors management. And the last is mHealth application. Right now or nowadays, we know that about 91% of the world population using phone. So this is the best opportunity for us to use that technology to reduce the risk of the recurrent cardiovascular event. Next. Okay, I think all I said before could be figured by this diagram. Yeah, this is the model of care process after patient with ACS. First, we have to make the risk stratification. Yeah, whenever the patient at the hospitalization, and it needs the counseling with a nurse and risk prediction score. After the counseling and the risk stratification, we can give the treatment target can involve the implementation of healthy behavior as I mentioned before. Next. Okay, so this is the conclusion of my presentation. The first discharge is not a one-time event, but is a complex process that takes place throughout the hospital stay. Yeah, the second one is discharge planning strategy for ACS patient requires multidiscipline approach and involvement of patient and families. And the last is a strict cardiovascular risk factors management and encouragement of healthy lifestyle in immediate post-ACL should be regarded as the highest priority. Now, this is the end of my presentation. Thank you. I will give it back to Ma'am Dian.
Okay, thank you. Thank you, Ma'am Andita, for giving us such informative and interesting presentation. Okay, ladies and gentlemen, now we come to the question and answer session. Yeah, I will limit only 6 questions here. Okay, you can press push raise hand button, or you can write on the chat box.
Berbagai jurusan kesehatan, adapun jurusan keperawatan, berjuta harapan serta impian. Menjadi perawat adalah suatu.
Okay, we have 2 questions to Mr. Dahrizal. Yeah, Mr. Dahrizal, this is 2 questions for you from Saum. First question for Saum. She asks you, what are the therapies that can affect the primary goals? What are the therapies that can affect the primary goals? And the second, can LDL lowering therapy only be done with a diet low in saturated fat and low in cholesterol, and low effective in this LDL lowering therapy in preventing coronary heart disease?
Okay, thank you very much, Ma'am Mardiani. 2 questions for me. The first question, what therapies can influence the primary goal. Ya. Indonesia, terapi apa yang dapat mempengaruhi tujuan utama kita? The goal kita itu adalah modification kolesterol, ya, LDL cholesterol, low density lipoprotein. The prevent atherosclerosis or plaque buildup in blood vessel, healthy lifestyle, and can be made the consuming foods that are low in bad fats, low salt, and control cholesterol levels and under 200 ya. Jadi untuk fokus utamanya adalah bagaimana mencegah aterosklerosis itu bisa terjadi. Ya, memang ini berlangsung long years ya, lama sekali, panjang. Jadi di sini kita menekankan adalah pengurangan konsumsi lemak ya, yang tinggi LDL, mengurangi rendah garam, dan tentunya adalah sini meningkatkan tinggi serat dari sisi konsumsi. Namun yang lebih baik lagi itu adalah accompany the exercise for at least. Itu direkomendasi adalah 10 and 50 minutes per day. Yang lebih baik itu adalah yang banyak kita pakai ya, itu adalah 150 minutes per week ya. 30 minutes a day atau 30 menit sehari. Bagaimana mengevaluasinya? Hot fluid ya. Di sini kita bisa pakai ya standar yang ditetapkan. The gold standard adalah menggunakan gold standarnya adalah angka 200 ya, 200. Kemudian less dikurangin umur. For example, for me ya. Saya 15 years ya, saya berumur 50 tahun, jadi saya harus masukkan angka 200 dikurangin 50. Ini sudah menjadi standar yang dipakai di beberapa riset. Ketemu angka 150. Kemudian ini kita untuk menghitung blood pressure ya, tekanan denyut nadi kita ya. Denyut nadi itu kita gunakan itu adalah di 70 sampai 75% ya, 75%. Jadi kalau dihitung 200 kurang 50 kali 75% itu sekitar 112 kali per menit. Itu pedoman untuk melakukan olahraga. Nah, jadi kita harus mencapai denyut nadi bagi saya yang berumur 50 tahun itu 112 kali per menit. Nah, itu akan melakukan gerakan atau memicu untuk terjadi perubahan baik itu di kolesterol kita dan juga terutama di elastisitas sistem vaskular, ya, elasticity vascular. Nah, ini banyak dipakai ya untuk bagaimana modification di LDL kolesterol. And then the second question, is LDL lowering therapy only possible with the diet low in saturated fat and low in cholesterol? And how effective is LDL lowering therapy in preventing coronary heart disease? Ya. Jadi di sini, apakah terapi penurunan LDL hanya bisa dilakukan dengan diet rendah lemak, jenuh, dan rendah kolesterol? Dan seberapa efektifkah terapi penurunan LDL ini dalam mencegah penurunan penyakit koroner? Ya. Not only with a low fat or low cholesterol diets, there are many ways to lower LDL in the body. For example, exercising regularly, reduce smoking habits, maintaining body weight. It is about the most effective way is to reduce foods and to contain high fat and not high cholesterol. Jadi tidak hanya dengan pola makan rendah lemak dan rendah kolesterol, ada banyak cara untuk menurunkan LDL dalam tubuh ya. Yang pasti itu adalah pengaturan makanan, asupan. Di sini yang dianjurkan adalah yang low, yang rendah lemak ya. Kemudian yang pasti adalah menjaga kebugaran dengan aktivitas fisik. Ya, aktivitas fisik seperti pedoman kita tadi adalah betul-betul mengontrol tekanan darah kita. Jadi tadi gold standardnya diambil di beberapa riset itu 200 kurangin umur dapat hasil. Tekanan darah kita adalah di 70 sampai 75%. Itu banyak risetnya di sana. Jadi kalau saya harus dengan umur 50 itu harus mencapai tekanan darah 110 sampai 115 itu aman ya. Ketika saya beraktivitas fisik. Jika angka itu tidak tercapai ya saya hanya dapat lelahnya saja, tidak mencapai ke penurunan LDL, juga tidak mencapaikan untuk melatih vaskular elastisitasnya. Maybe itu, Mem Mardiani, thank you very much for me. Thank you.
Thank you, Mr. Darizal. The most important is to keep normal cholesterol level, yeah, and then maintaining body weight and control blood pressures. Okay, the next question from Mr. Chandra to Ma'am Andita. Yeah, the question: Who is the responsible to take the discharge planning to the patient? There is need the special capability. Okay, Andita, you clear with the question?
Okay, inshallah, ma'am. Thank you, Mr. Chandra, for the question. I think the question is very interesting. Yeah, as a teamwork, whenever we talk about discharge planning, it involves multidisciplinary. The physician and the nurse, the pharmacist, and then the nutritionist, and maybe we need the involvement of medical rehabilitation team. In hospital right now, as far as I know, we have a person named case manager. So the case manager actually have a responsibility in manage the patient, every patient, from the very first, since the patient register until the patient is already to discharge. So the case manager should be able to give coordination to another team member. What should we do and what should we plan to the patient? Do the patient need some source, for example, the need to health education, for smoking cessation, for a healthy diet maybe, and after the coordination, all the teamwork should develop the special plan of care in every patient, yeah, in each patient actually. And it's not general, we have the specific plan for every patient. So if we ask who is the person that should have a responsibility, the answer is the teamwork. And who should be the leader? So the leader can be the case manager at the clinical practice. And maybe there is a question then, yeah, who is the case manager? Usually the case manager is the person that chosen by the institution, I mean the hospital, and the educational background, usually a nurse, the senior nurse actually, yeah, but it's not close the possibility if the younger one, which have a lot of experience in, I mean, the clinical settings, can be involved or chosen as a case manager. Thank you.
Thank you, Ma'am Andita. The next question from Bobby, yeah, from Bobby to Ma'am Endang. Yeah, Ma'am Endang, yeah. Bobby have experience. I want to read the Bobby right on the box. He was one encouraged a patient after having a ring placed in an artery caused his blood pressure to rise rapidly, even more than before the ring was placed. Even more than before the ring was placed. The question is, why is blood pressure still high after stent placement?
Okay.
Okay,
Thank
thank you.
you, Ms. Dian. The question is why? Sorry, I want to ask a question first. Before,
Why?
okay, before the ring is
Was
the
placed, yeah. Was
placed,
placed. But
there is
the hikes,
hypertension before.
yeah, the blood pressure still high.
No. Before the ring places or
Yeah.
before there is acute coronary syndrome in that patient, is there hypertension in that person? Maybe I
Yeah.
want to ask before. Okay. Actually, placement of the ring is not associated with hypertension, but we inflate the balloon is for reperfusion the occluded vasoconstriction vascular artery vascular, right? So if the patient first there is hypertension, and then after he had acute coronary syndrome and had occluded of artery coronary, there's no association. The patient will lower the hypertension base. The answer, Miss Dian. So sorry, aku pakai bahasa Indonesia aja kali. Jadi kalau misalnya nih si pasien ini sebelumnya memang ada hipertensi, udah gitu dia ada acute coronary syndrome, karena si acute coronary syndrome ini faktor resikonya adalah si hipertensi salah satunya ya. Dan pada saat si steminya atau si oklusinya di reperfusi, dia memang tidak akan berpengaruh terhadap hipertensinya, karena pada saat dia mereperfusi si vaskular koroner, dia hanya di posisi yang oklusi saja, tetapi kejadian hipertensi ini merupakan kondisi yang berkelanjutan pada pembuluh darah di tubuh kita, tidak hanya di koroner. So hypertension, there's no association with reperfusion or placement of balloon. So if the patient still hypertension, is because of the condition of the vascular in that their body is still had a factor of hypertension. Maybe it's my answer, Miss Dian. Jadi kalaupun misalnya si pasien ini sudah ada hipertensi sebelumnya, karena hipertensi ini merupakan proses yang panjang karena terkait dengan remodeling dari si pembuluh darah, tidak hanya di koroner tetapi di seluruh tubuh pembuluh darahnya. Jadi pada saat walaupun dia sudah di reperfusi, karena kan yang di reperfusi hanya di koroner aja tuh ya, sedangkan di pembuluh darah lainnya tetap ada, bisa jadi ada aterosklerosis dan yang lainnya ya. Jadi tidak menurunkan hipertensinya itu. Kalau maybe why with pain the hypertension could arise, karena because of pain will increase the adrenaline and increase the blood pressure. Sorry, it's my answer, Miss Dian. Sorry.
Okay, thank you, Ma'am Endang. It's mean hypertension, the long process, yeah, the long process, and do not connection with the stent placement. Okay. Okay, thank you. Maybe this is the last question, yeah, the last question from Galuh Polkeslu. She to Ma'am Andita. The question is, what should a nurse assess regarding to discharge planning? I repeat, what should a nurse assess regarding to discharge planning? Ma'am Andita, please, you can answer this question.
Thank you, Ma'am Dian. So the question is, what is the assessment for a patient after ACS that nurse should be done? Yeah, I think the first is we have to just assess, yeah, the risk stratification of the patient. And then the second one is we have to also assess not only the physical aspect of the patient, but also the psychological aspect that can contribute to the health of the patient. Because as we know that one factors that contribute to acute coronary syndrome is psychological aspect. So we have to make a deep assessment regarding to the condition of the psychological aspect of the patient. And the next is we also should assess how far the need of education, health education of the patient and family. How far the comprehension of the patient and families regarding to ACS, regarding to the medical therapy, regarding to the risk factors, regarding to maybe the factors that can contribute to the next event of heart attack, yeah, maybe. And the last is we have to assess what source does the patient and family have in community that will support the patient and family gone through the discharge process. I think that's all, Ma'am Dian.
That means the help source to support that process, yeah. Okay, thank you, Ma'am Andita. Ladies and gentlemen, all questions have been answered. Thank you very much to our speaker today, Mr. Darizal, Ma'am Andita, and Ma'am Endang. Yeah. Now time to give the online certificate to our speaker. Please welcome our director to give the certificate to Mr. Darizal, Ma'am Endang, and Ma'am Andita.
Okay, thank you, Ma'am Dian. Thank you very much to Mrs. Endang
Okay,
Sulistiawati from Hospital Jantung Harapan Kita, Jakarta. And thank you, Mr. Darizal and Mrs. Andita. Hopefully the knowledge is useful. Here we submit a certificate as result person of this is useful. Thank you, terima kasih banyak Bu Endang, Bu Andita, dan Pak Darizal, luar biasa. Bu Dian juga luar biasa, Mem Dian, terima kasih banyak. Termasuk peserta yang saat ini masih berada di posisi 400 lebih.
Thank you, Ma'am Eliana.
Thank you, ma'am. Thank you.
Okay. For the minute, I beg your time second for our speaker, yeah, to take a photo together with all participants. Mr. Darizal, wait a minute. Ma'am Endang and Ma'am Andita, we take a photo before. Okay, take photo, please. Okay, next.
Endang Mas Ibu. Bu Endang harus.
Next. Next. Okay, next. Next, finish. Okay. Okay, thank you for our speaker today, Pak Darizal, ya, Mr. Darizal, Ma'am Andita, and Ma'am Endang. Okay, ladies and gentlemen, today we finish our seminar. Before I close the seminar, I would like to take the conclusion from our speaker. Yeah, the conclusion is nurse laborers to take opportunity to revolution traditional models of care. HM model, collaborative development process, solid technological infrastructure, clearly defined responsibilities. ACS should be diagnosed as soon as possible. Reperfusion is the goal for treating ACS. Nurses play a critical role in assessing, monitoring, and caring. Discharge is not a one-time event, but it's a complex process that take in the hospital stay. Discharge planning strategy for ACS patient requires multidiscipline approach and involvement of patient and families. Healthy lifestyle in immediate post-ACS should be regarded as the highest priority. What are the trend and issue is the application of holistic care application carried out by nurse in modifying risk factors and discharge planning and care management in ACS patient. And the last, I would like to thank the speaker again for the informative and interesting presentation, and all the participants for the very active participation. Finally, give the applause for the speaker and for you all.
Thank you, everyone. Thank you, Miss Aliana, Miss Dian.
Okay, thank you, Ma'am Enda.
Thank
See
you.
you on the next seminar, maybe, yeah?
Yeah, I'm sorry with my bad English.
It's okay, the same with us. Okay, thank you all. And finally, I want to say thank you and wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Sukses semuanya.
Thank you. Thank you, Ma'am Endang. Thank you, Ma'am Eliana.
Okay, thank you very much for So thank you so much, Ma'am Mardiani. It's such interesting discussion I ever seen. So welcome back again, ladies and gentlemen. We're back again. I hope that all participants can participate in this event until the end. Before we close this event, don't forget to all participants to answer the post test according to the link that will be shared by admin on live YouTube and room chat on Zoom meetings. I will give you the 2 minutes to fill the answer of the post test. Okay, participant, after you finish your post-test, I wanted to inform you that you have to fill the list of your attendance and evaluation on the link at live YouTube and group chat on Zoom meeting. Okay, participant, make sure that you fill the link of attendance that admin shared to the link group. Well, everyone, the committee has prepared the prize for 5 participants based on the highest pretest and post-test score. And the names of participants are Relis Nopiantri, are you here? Relis, are you still here in the Zoom meetings? And the second winner is Koirun Nisa Wandani. You can raise your hand when I call your name. The third is Saprita Sulistina. The fourth is Chandra. And the last is Suhadi. For the 5 participants, are you still here? Iya. So this is the name of the winner of our discussion today. They are Relis Noviantri, Koirun Nisa, Saptri Okay, ladies and gentlemen, so that's the series of events for the international seminar with the theme Management of Patients with Acute Coronary Syndrome. I am Arzala Sari, as the Master of Ceremony and Committee Representative, would like to say thank you so much for all the participants. And we also apologize if there are actions that are less pleasing. That's all from us. Wassalamualaikum warahmatullahi wabarakatuh. Thank you, everyone.
Bengkulu is a province in the southwest of Sumatra Island. Nature, culture, and history become one, and it known as Bumi Rafflesia. Politeknik Kesehatan Kementerian Kesehatan Bengkulu was established on April 16, 2001. Poltekkes Kemenkes Bengkulu is ready to be an excellent health college that provides professional health workers and lead to global in 2025. Our alumni have worked domestic and abroad that spread in Japan for 63 people, Taiwan 20 people, Saudi Arabia 2 people, and Germany 1 person. Poltekkes Kemenkes Bengkulu is one of the excellent state health colleges in Bengkulu province. The main campus is addressed at Jalan Indragiri, number 3, Padang Harapan, Kota Bengkulu. Meanwhile, Campus B Curug is addressed at Jalan Sapta Marga, number 95, Teladan Village, Rejang Lebong, Regency. Poltekkes Kemenkes Bengkulu is equipped with the complete and modern campus facilities to support the learning process, including the training center building has more than 2,000 meter square areas with a hall that provides 500 seats and a comfortable inn. Auditorium has more than 3,000 meter square areas that provides 1,500 people that used as a multi-purpose building for both internal and external activities of Poltek lecture buildings. Integrated laboratory consists of laboratory department of nursing, midwife, nutrition, health analyst with adequate campus equipment. Campus gazebo with 128 meter square areas used for student discussion place. Tarbiyati Siham Mosque has 457 meter square areas for 500 people with an open room design. Port facilities. Unit of Language Development with Internet connection and 44 computers unit for computer-based tests and online TOEFL tests. A comfortable library with selfie corner and Selayang Anti-Korupsi corner. Unit of Information Technology that provides computer-based tests with 145 computers unit. Home theater that is used for audiovisual learning activities to all departments. Currently, Poltekkes Kemenkes Bengkulu has been accredited by BAN PT with predicate B, and it has 6 majors and 14 study programs that are already accredited by LAM PTKes.
Percayakan pendidikan putra putri Anda menjadi tenaga kesehatan profesional bersama Poltekkes Kemenkes Bengkulu. Poltekkes Kemenkes Bengkulu. Siap, aku. Berkualitas, Polkeslu. Bersedia.
Baik, terima kasih semuanya.